Hello. Hello, good morning.
Good morning, sir.
Okay, good morning. How are you?
We're fine. Thank you, sir.
Yeah, thank you too. So I'm happy that everybody can hear me. So I think it's only 4 of us are online at the moment, and it's already 7 minutes, 6 minutes after 7. Do you think we can start, right? We can
There
just
are about there are
come
about 13 of us, sir.
now.
There are about 13 of us that are online, sir.
Only how many? Okay, about
13.
30 of us, right? Oh, that's
Yes,
good.
sir.
I can see only okay, okay, this I can see. So I can just start, right?
I- I- Yes, yes, sir. I think it's okay
It's
because the
okay,
time
right?
is already going. Yes, sir.
All right, thank you so much. Okay.
Okay, thank you, sir.
Okay, let me share my slides. Okay, I can share my slides now. Bismillah. Okay, is my slide coming on? I'm trying to share my slides. Okay, please, can you allow me to share slides? It's just showing that the host is not allowing sharing for this meeting. Please, can you allow me to share slides?
Okay, sir. Let me talk to Dr. Huzaifa. He's hosting.
Oh,
Okay.
okay.
I will, sir. You can share now, sir.
Okay, thank you so much.
We can see your screen now, sir.
Okay, you can see my screen now, right? Okay.
Yes,
Come
sir.
on. Okay. All right. Good morning to you all, and I'm glad to do this presentation today. So the topic is about upper limb rehabilitation after stroke. My next slide is going to talk about what I'm going to present today. So the objectives of my presentations are to just make us understand impairments that happen after stroke related to the upper limb, and the key assessments we can also make to know what happened or what's wrong with the upper limb. And also those key assessments will also inform the kind of rehabilitation strategy we can use for the patients to get better. But predominantly, I'm going to talk about therapeutic-based exercise interventions, particularly partly because talking about upper limb rehabilitation is actually very, very, very broad. So I'll concentrate on the movement therapeutic exercise-based interventions. Then another thing I want us to understand is also the issue of clinical decision-making and clinical reasons pertaining to upper limb rehabilitation. So what do you do? What are strategies we can employ to maximize the impact of our intervention? So these are the things I will talk about. So the next slide we'll talk about just a little bit of what stroke is all about, what happens, what causes stroke, and all that. So I'm not going to talk about I'm not going to go deeply into epidemiology, but I will talk about what causes the stroke, and we move on to the impairments that occur after stroke. So first of all, there are two basic ways through which stroke can occur. One is through ischemia, and when we say ischemia, when there's reduce blood supply to the brain tissues, brain areas. And what happens is that something happens that is called thrombus, occurs usually in the carotid artery, which gets transferred or lodged into the arteries in the brain, particularly the cerebral arteries, the middle cerebral artery, posterior cerebral artery, and so forth. And another way we can develop stroke is through what is called hemorrhage. That's the bursting of the blood vessels, small blood vessels in the brain, and it's usually due to aneurysm, which is just ballooning of the blood vessels. And under serious intracranial pressure, that may cause bursting of the blood vessels, and the blood within the vessels will now be flooded into the brain regions and cause increase in intracranial pressure as well, and cause damage to the brain cells. So these are basically two ways we can develop stroke. So what are the functions that get impaired when someone has stroke? Basically, there are so many functions that the brain actually carry out. So those functions are the functions that will be impaired if someone has stroke. One of them is the control of movement, which is called motor functions, and there are so many mechanisms through which that will happen. The land-noise phenomenon, apraxia, neglect, and so many other ones. But I will talk about the land-noise phenomenon, apraxia, and also neglect. The sensory function may also be impaired, and cognitive function may also be impaired, and as well as autonomy functions such as bladder control, anal control, and so forth. So there are so many things that can occur actually, but basically these four are the ones that predominantly occur, and the ones that are actually responsible for the disability that people with stroke have. Most importantly, the motor function is actually contribute the highest percentage of disability in following stroke. So I'll go to the next slide, please. So before I will talk about the impairments that occur following stroke, I would like us to understand how the brain controls human movement, because my talk today is going to center mainly on rehabilitation of motor function. Like I said, rehabilitation of the upper limb is actually very broad. You have to consider many other things, but even the motor functions, which actually contributes the highest percentage of consequences of a disability after stroke. So it actually deserves so much attention. So I'll concentrate on the motor function aspect of that. So what actually controls human movement? How does it actually control? This chart is from a book chapter by Bernard in 2010. And if you look at this chart, there are three important areas of the brain that are actually involved. That's the M1, the primary motor cortex, the cortical area, the primary motor cortex, right? And its main function is actually to execute human movements, to plan and execute the human movements, actually. That is its function. So it generates nerve impulses, which are now sent down to the effector organs, the muscles, for them to actually move. Then we have the premotor cortex and the supplementary motor areas. These three areas: the primary motor cortex, the supplementary motor area, the premotor cortex are actually very important as far as control of human movements is actually concerned. For instance, the the cortical areas will send motor commands to the supplementary motor areas, and also to the premotor areas, which will now send motor commands as well to the brainstem and the spinal cord. Then the motor cortex as well. The primary motor cortex as well can also send motor commands to also the spinal cord, and the cortical areas, the cortical regions, the primary motor cortex and the premotor cortex, and especially receive visual information from the visual cortex, and all these things are integrated in what is called the sensory motor integrations, and movement is actually produced normally. So this different areas of the brain, the ones that integrate their own actions, their own functions to produce normal human movements. So any disruptions, any injury to these areas can actually result in what? Impairment in motor functions. So I'll go to the next slides. So the next thing I will talk about is the Londonese phenomenon. So when there is an injury to the brain and motor functions is about to get impaired, will get impaired, there are basically things that happen. One of the phenomenon is called the Londonese phenomenon, which is actually explained by Top et al. I think around 1965 or so, if I can remember. And what they said that is what Top described was if there's an injury such as stroke, what happens is that the function of the nervous system gets depressed. Yeah, and the motor activity actually gets reduced, gets impaired. It actually gets depressed. And that depression is not necessarily because the injury is as severe enough to cause motor function disruption, because that's the normal process. It just depresses the CNS and the motor activity. I can give an example. If something panicked you, something got you scared, and so maybe you're just walking along a street, and something got you scared. So anytime you want to walk in that street, actually you'll be reluctant to actually walk because of that scare that you got, that scare that you were scared actually. So the same thing, if there's an injury, even if the injury is not actually enough to disrupt functions, that injury can cause depression of the nervous system. And if the nervous system is actually depressed, the consequence will be what? Will be, let's say someone had a stroke in the night, and that person wakes up, and as he wakes up, he just wants to use his hand maybe to carry something, or he wants to just raise himself up and walk on his legs. But he unsuccessfully did that. He couldn't do that actually. So that unsuccessful attempt, what will actually result in so many things. One, that failure will now encourage him not to actually attempt that activity. That's number one. And maybe because, okay, he's trying to walk to stand on his legs, or he tried to use his upper limb, for instance, because we are talking about the upper limb, and there was pain in the upper limb. Then that pain will also discourage him from doing that particular activity. And what will result in what? Suppression of that activity. Because of that pain, because of that fear, because of that failure, that activity will not be suppressed. Yeah, any attempt you want to do any attempt you want to make to do that will actually get discouraged psychologically by your mind, because you attempted and you failed. Maybe because there was pain, you thought that, okay, if I do this, I will reproduce the pain. The pain will also cause problem to me. And that was what? That depression of the motor activity, because of these factors that we mentioned, will result in what we call learn non-use. Because of that, the patient will behaviorally learn not to actually use that limb, and that will cause a lot of so what that will cause the behavior that we call the learn non-use phenomenon. That's one way anyway. In another way, that depression will also cause what? Will also cause less movement. Of course, actually, yeah, because there is depression of function, and you thought that I can't do this thing because maybe something has happened to me, then that will result in what is called the less movement. And if there's less movement, the brain will also react. Yeah, just like our musculoskeletal systems. If we lie in our beds, maybe because we are sick, we are bedridden, maybe we are sick, we are confined to our bed in the hospital, or maybe in the ward, or maybe at home, and we don't walk around. What will happen is there's going to be atrophy of the muscles, right? The muscle will atrophy. The same thing with the brain. If there is less movement, the cortical areas that control that movement, that actions in the brain, in the cortical map, actually will also get contracted, would actually reduce in size. It will shrink. It will shrink, right? And that shrinking of the cortical areas will also result in effortful movement. So if you want to make movement, if you want to move that side, instead of you to use little effort, now because the area is actually being reduced, there is no help actually, because the area that control that movement, which was actually bigger before the injury, it was actually easy for the patients or for the client to actually move that part of the body. But because of the shrinking, the contraction of that cortical map, it reduced, the help will be like now little, then movement is going to be what? More effortful. They have to make more efforts to make what? To do that movement. And that will also what? That also lead to what? To also learn new phenomena. Because the patient feels that, okay, now I have to make more efforts. So instead of me to make more effort to use this hand, why not use the unaffected hand for carrying out activities of daily living? And that will result in what it's called the learn new phenomenon. Another way this will also happen is that unsuccessful movements, if there is depression of the nervous system functions or the brain functions, that unsuccessful attempt that patient made will also lead to what? To lead to compensatory behavior. Yeah, I now use my right hand, and because it's been affected and I couldn't do that, then the simple strategy, the simple solution I will immediately find is to use what? The unaffected limb, right? So that will result in what is called compensatory behavior and behavior pattern. So I'll now begin to use what? The unaffected limb. And if I now use the unaffected limb and I was able to fulfill my own desire, I was able to achieve what I want to achieve, definitely that will result in, okay, anytime I want to use my hands to carry out something, or maybe to pick a cup and drink water from it, I will use what? I will use the unaffected limb. And that will also strengthen what? The use of the unaffected limb. Yeah, leading to what? Leading to culmination, leading to learn behavior. So when you look at these three phenomena we talk about, the less movement, the unsuccessful attempts, and the compensatory behavior, all of them, when you put them together, they lead to what is called what? Learn phenomenon. Normally permanent. Sometimes actually it can be permanent, yeah, without rehabilitation. And that's why we institute rehabilitation as early as possible, so as to reverse that kind of behavior that patient actually adopted. This is actually a phenomenon described by Taub long ago, and actually it actually laid foundations of so many interventions, in particular the constraint-induced movement therapy. But there are also criticism as to how adequate or how accurately this phenomenon actually describe what happened after stroke. But even though there are those criticism by Toke et al. And I think many others, but I think it still remains one of the best model to explain what happens actually after stroke. So another thing that happens that might lead to the impairment in motor functions that we need to actually be careful and understand is actually the apraxia. So when we say apraxia, it's just the inability to carry out praxis movements in the absence of elementary motor, sensory or coordination deficit that could serve as the primary cause. So someone with non-use phenomenon, even if there is no any impairment in motor functions or sensory functions or coordination deficits, apraxia can also be one of the reasons why patients do not use their the upper limbs. And when we say praxis movements, we are talking about those skill movements that we actually performed. For instance, buttoning our shirts, tying lacing our shoes, and all that. These are examples of praxis movements. So there are three types of apraxia. One of them is the idiomotor apraxia. The other one is the ideational, and the last one is the limb kinetic. So what are actually all these ones? So there are two ways that models, two ways that are used, two ways that were used to explain what apraxia is all apraxia. So they feel that by Lippmann model feels that actually why apraxia occurs is because there is involvement of corpus callosum. That's the resultant of the information flowing anteriorly from the posterior brain regions such as the occipital and parietal lobe. So when you look at the brain, the corpus callosum. Hello, can you hear me, please? Hello?
Yes, sir, we can hear you.
You can hear me clearly, right?
Yes, sir, we can hear you clearly.
Okay, thank you so much. So one of the models explained that it's the disruption of the corpus callosum that causes. This someone is talking from the other. Okay, Yeah, so the one of the models explained is by Littman, and what he believed was that apraxia occurs because of involvement of the corpus callosum. Corpus callosum is actually the largest connecting part of the brain that connects the two hemispheres actually. So if there is disruption of that connections, which obstructs flowing of information anteriorly from information from posterior part of the brain to the anterior part of the brain, that may result in in apraxia. Nomad Guestwent believes that it actually is superior fasciculus, and disconnection of the left premotor cortex and Wernicke's areas actually are what actually causes apraxia. So what is actually idiomotor apraxia? Like I mentioned, there is idiomotor, there's additional, that also limb kinetic, right? So in the case of idiomotor apraxia is when you ask the patient to demonstrate how to use a spoon. Now, you ask the patient to demonstrate to me, please, how you can use a spoon. The patient can verbally say, okay, this is what you do, this is what you do, this is what you do. But if you ask him to do it, practically he cannot be able to do that. That's what is called what? That is what is called idiomotor apraxia. But idiotional apraxia is characterized by inability to conceptualize a task by using the correct sequence required for the task. So now, let's say I want to wear my onset. Somebody had a stroke and he wants to wear their onset. The normal sequence is what? To actually put slip in one of the hands and the other, and just slip the neck also. Slip in the neck, you are your onset, right? That's the normal sequence, right? But if you ask someone with additional apraxia, that he cannot be able to conceptualize the correct sequence of that action. Then the other one is what? The limb kinetic apraxia. I think this one is actually very much more important than the others as far as our today's discussion is concerned. In the case of limb kinetic apraxia, what happens is the loss of ability to make precise, independent but coordinated finger and hand movements. So apraxia can lead to what? Lead to making precise and independent coordinated finger and hand movement. So it actually one patient can be able to make appropriate skilled movements, and the way you can know that someone is having apraxia is when he has clumsy movements. For instance, if you ask him to hold a pen and maybe write letter A, you can see the way he write the letter A is going to be really very small, clumsy, because there's clumsy movement. So that's about that. So another thing that can affect motor function, in particular of the upper limb, is what? Neglect. Sorry, I use our Emir of Kano, Snusi, not just to denigrate him, but just to catch everybody's attention, to just look at. So look at how he's looking at. I think from your on side, you can see now he's actually paying attention to the right, neglecting the left side. So it's just for us to understand. When I was a student, my professor used the Queen of England, so I think I adopted from that. So let me just use our Emir. So, so when we say neglect is just refers to failure to report or respond to or orient to or meaningful stimuli or stimuli presented to the side opposite of the brain region by Hellman 1990. I think it's actually the commonly used definition of neglect. So what neglect means is that when you fail to orient yourself, be aware of. Please, can we stop talking, please? I'm sorry. Yeah. Pertaining to the opposite side of the brain, opposite side of the brain region, that's contralateral side, is the one that is actually being neglected. So if one cannot be able to perform tasks in that area, or cannot be able to, when you are touched, you cannot be able to feel, because the neglect actually it has so many classifications: sensory neglect, motor neglect, and so forth, even representational neglect, right? But the one we are concerned with today is the motor neglect, which I will talk about in the next slide. I think Badru has talked about this one last week, so there is no need to reinvent the wheel. So the motor neglect actually means failure to generate movement, response to a stimulus, even though the person is aware of the stimulus. Yeah, it's also called inattentional and also article neglect. So the way you know that, okay, the person is actually not able to generate movements, even though what the person response to a stimulus, even though the person is actually aware of that stimulus. Okay, if I say, okay, please, can you raise your hand up? Can you take your hand to the mouth? The patient can what? If he's having a motor neglect, the way we see that there's going to be hypometria. Hypometria is what? Slow or short amplitude movements. Slow amplitude movements. That's if I now ask the patient to carry his hand to the mouth or to the nose. The person will attempt to do that, but will fall short of that. Maybe he will just leave it around his own stomach, around his own chest, and it doesn't get there. It's not that the person does not have the ability to do the movement, but because of his motor neglect, the movement is going to actually fall short of that, what I asked him to actually do. That's what is called by hypometria. There's going to be hypokinesia, slow movement, and there's going to be what bradykinesia. These are the three ways we can understand someone is having actually motor neglect. So these are the things we consider. Not only that, okay, our patient is having paraplegia, hemiplegia, hemiparesis, and all that. These are not the only things that we should also consider. We should also consider other causes, other things that can lead to the impairment in motor functions, that can present as impairment in motor function. So I'll go to the next slide. So pertaining to the upper limb impairment, in most cases, patients with a stroke, about 35% of them, usually from 20, even I saw some papers that talk about even up to 80%. But we know even in practice, most of our patients that we present in the clinic do have impairment in upper limb, especially motor function. And another thing they may have is also loss of fractionated movement. By fractionated movement, it means ability to voluntarily move one segment independently of the other segments. Let's say I want to move my wrist joint. Under normal circumstances, if I don't have any problem, I can be able to do that independently of moving the elbow joint or moving the arm as well. But in people with stroke, they usually have loss of this fractionated movement. So trying to move, they don't normally be able to move a segment of the part of the upper limb or the body independent of the other. Then we can also have an abnormal muscle tone, flacidity, spasticity. We can also have loss of somatosensation, sensory impairment, light touch will be impaired, proprioception will also be impaired, vibration is also be impaired. I'm talking about these ones, loss of somatosensation, because these are actually very, very important as far as the rehabilitation of the upper limb is actually concerned. So we will talk about so many interventions that actually utilize somatosensation for them to be effective. So this by Plahati and Ali in 2023. They used the ICF framework, International Classification of Functioning and Disability, to actually map what happens actually to the upper limb after stroke. So let's say the health condition is actually stroke, and the health condition here we are talking about is actually upper limb motor impairment, because I said we concentrate more on motor functions. So the impairment that actually happens, that results, that affect upper limb is actually actually reduce muscle power. Well, I tend to disagree most times when people talk about motor power when it comes to strokes. I think the preferred what should be the motor functions, which muscle power is actually an aspect of. So I think we call it motor function. There might also be increased tone and what we might be manifested as spasticity, particularly for the upper limb. What we call the flexors synergy, right? Usually have spasticity in respect of the flexors of the elbow, flexors of the small joints of the hands and the wrist. This is what we normally have. So when people have that, what actually is the consequence? What happens actually? There's going to be impaired in activity, impairment or disability actually. There's going to be disability. People may not be able to use the hand, maybe to hold an object, to perform ADL, use their hands to eat their food, put on their forehead, groom themselves, wash their faces, even use their hands to wear their clothes and all that. These are the things that can be actually affected as far as disability is concerned. Then in terms of participation, what will happen is that it will impact on social life and leisure activities, recreational activities, and even work even work. Assuming the person is actually a teacher, a lecturer like myself, and had a stroke, and he has to use a board marker to write, or he has to use a chalk to write on the board, that will actually affect him. Assuming the person actually a basketballer, is actually a tennis player, cannot be able to do that, and it will affect him in all aspects of his life. So all these things can can affect some person personally, and can affect even his environment. And also the personal factors also can also affect the impairment itself, can also affect what? Can also affect the disability, can also affect participation. Let's say as environmental factors. In the environmental matter, if you have a very supportive family, a very supportive friends, spouse, kids, and all that, yeah, and you have good professional support, right? That can what? That can lessen the burden that you will feel when you have a stroke, right? And that can actually affect a lot of things. The healthcare professional also, if you have very good healthcare professionals who are very up and doing, who are very competent, that will also lessen your onboarding. You know, they are doing their best, and they are doing have the confidence that you will actually get better. Personal factors also, age also matters a lot. People that are very elderly, that may be actually very difficult on them. People that are very at their prime age, yeah, they may find it very easy to adapt and even perform the exercise that are actually recommended for them with the rehabilitations. Also, difference between men and women. Some may be more motivated than the others. Then marital status, I think about talk about that, and also lifestyle, and also motivation, and also socioeconomic factors. If you are well-to-do, you can afford the best treatment ever. You can buy adaptive equipment as expensive as they are. You can do that. So all these things can also affect. So, but one of the most important things we can do before we can make a clinical decision on what type of intervention we should use for upper limb rehabilitation, I think it's actually very important to know what is actually happening, what is actually the problem that is happening to our upper limb. And we can do that by what? We can do that by assessing many aspects of functions, impairment, disability, and maybe participations. We can do that actually. So one of the assessment tools, some of the assessment tools we can use, there are so many assessments, so many of them actually, so many for the upper limb. And I think for a very busy clinician, it will be very difficult for you to choose which one you can use. And even more so that using these outcome measures can take a hell lot of time from your own daily schedules. But I think I can recommend this actually. I think 4 or 3 of them, World Motor Function Test. Fugl-Meyer is actually a little bit big, but World Motor Function Test actually, which is used for the assessment of motor function, is actually not really, it doesn't really consume time. Then there's also motor activity log. That one is actually, why it's actually easy to administer is because you just ask the patient to tell you. So then there are others, Jepstown-Taylor hand function test for dexterity and hand function, 9-hole peg test. A lot of them, I think last week someone has discussed about assessments following stroke, so there is no need to worry much about that. But I will talk about the motor function a little bit, and I also talk about motor activity log. So these are actually the World Motor Function Test, and it has 2 components. It has functional ability. It has what? It has its time component. So you assess what the time it takes the patient to perform that task you ask them to do, and you also assess what the functional ability. So we'll talk about how those things are actually done. So this scale O2 for the measurement of assessment of motor function has about 17 items. Has 17 items, and although that 2 of the items have to do with strength, but sorry. So you can see that the first activity, the first task you ask the patient to do is to ask the patient forearm to side, to move his forearm to the table. Yeah, you have a table in front of the patient. You ask the patient to move the arm toward the table, and you correct that one. You correct the ability. How to read the ability? You correct the ability from 0 to 5. The higher the score, the higher the score, the better the ability. So 0 is the lowest ability, and 5 is the highest ability. So we have so many items. Another one is forearm to the box, extend elbow weight with weight, hand to table, hand to box, weight to box, reach and retrieve. Yeah. So, but weight to box is actually measuring strength. So You can do it in two ways. At the end of the day, you can either remove item number 7 when you are talking about performance, and also item number 14. Right, yeah, because you are not rating them, unless if you just want to rate them. If you are rating them, you can actually include them, but they are usually what measures of what? They are measures of power, measures of actually muscle strength. But what I normally do for my patients, I actually rate them the same way I rate all the other ones. So I just ignore the issue of the strength. So at the end of the day, I was going to have 17 items. So how do we know that, okay, what does 0 stand and what does 5, 1, 2, and actually stand? So when we say 0, we mean that the patient does not attempt with upper extremity being tested. So if you're testing the upper extremity, the patient actually does not, when the patient does not attempt, you give a score of 1. And when the patient does not perform functionally, however, attempt is made to use, the patient is actually trying to make an attempt, but that is not a functional. You can give 1. If the patient requires assistance if the patient can do it, the patient can try, but at the end of the day also use an assistance from the what? From the unaffected limb, you now can score that too. But if the patient can move, movement is influenced to some degree by synergy, or is performed slowly or with effort. If the patient is performing the task with an effort, or actually maybe is actually being influenced by flexor synergy, then you can say what? You can call that movement actually 3, or the movement is actually performed very slowly. Then if the patient, the movement that the patient performed, the task the patient performed actually is very close to normal, you can call that what? You can call it 4. When it's actually, it appears to be normal, you call it what? You call it 5. So that's how to what? To grade the tasks that are in what? That are contained in a multiple function test. So another scale is the what? Is the motor activity log. And this one is what? Is just relies on patient self-report. So what you do, you have like 13 items, 30 items. I think there is a shorter one, I think, which has about 18 items, right? 18 items there, yeah. And I think there are also some of the tasks that may not actually be relevant on part of the world. So you can as well anytime make a compromise. And I know of a validated house version of that, but it didn't actually consider some of the tasks that our participants, we did remove some of the tasks that our patients cannot do, even though we identified like about 2 or 3 tasks that are patients, that are not relevant to our patients. So if you remove those ones, you can actually administer that. So in this case, this one is also what? Is also be rated on a scale of 0 to 5, like the other one, almost like the other one. But in this one, it has what? 2 subscales. One, it assesses the amount of scale. That's the amount, how regularly, how frequently you use the arm or the upper limb for that particular task. And the other section is also for what is called the how well. And that how well is how well, the quality. How well do you do it? The quality of doing that particular task. You also rate that one. But this one, you just ask the patient. The patient will tell you, okay, are you able to do this? It's okay. Turn on light with a light switch. How well do you turn on light with a light switch? Oh, how well do you do that? Oh, okay. How frequently do you do that as well for the amount scale, for the quantity scale? Then for the quality scale, you ask how well do you do that? Then you can rate what? You can rate them on that 0 to 5 rating score. But so there are, like I said, there are 30. It has 30 items. And you can see what for the first item is talking about turn on a light with a light switch. Number 2 is talking about open drawer. Number 2, remove an item of clothing from a drawer. Number 4 is talking about picking up a phone, and so forth. Number 7 is even talking about how do you open your refrigerator, right? So if people don't have a refrigerator, I think you can make a compromise. Look at anything, something that looks like a refrigerator, if they have in the house, and ask about that. So like I said, there are those 30. The number 20 is I'll pick up a glass bottle, drinking cup or a can. So the patient will rate how well he does that and how frequently he does that. He will tell you, then you now can mark that ability on what? On the 0 to 5 rating scale, which I will explain subsequently. So we have a lot of them. Number 23 is talking about use a key to unlock a door. Then we have write on a paper, a lot of them. So pick up a cup by a handle, all those tasks you can ask your patient. You can read. And so, so how do we actually, this is for the amount scale. There is also for the how well scale, that's quality scale. So if the patient did not use, said that he doesn't use his weaker arm, he actually relies on the unaffected limb for what? For carrying out those tasks. So what you do, you what? You give that 0. Yeah. So there's also, and in between that, there's also a score of 0.5. And this one is also left to your own discretion, because it's actually, the rating of this tax is actually, this tax is actually very, very subjective. So assuming the patient said, okay, I do not use the weak, I do use the weaker arm. I do attempt. I do attempt with the weaker arm. You can actually score that 0.5. Then number 1, you can score 1 if occasionally the patient actually said that he occasionally use weaker arm, but only very rarely. Yeah. So he said, okay, very rarely. But he said very rarely. If he does use it rarely, maybe sometimes, very rarely, maybe really something less than that, actually more than that, you can give it 1.5. But if you use the weaker arm sometimes, which you can call sometimes, you can also actually give it 2. If sometimes, yeah, if you use it the weaker arm actually, as much as half of when he used to, the way he used to use it before the stroke, maybe half, 50% of. Yeah, I predominantly use my weaker arm before the stroke, but now maybe I can say I can give it 50%. I use it 50% of the time. You can give it 3. So anything less than that, you can give it 2.5, right? Then 4, if the patient used the weaker arm almost as much as before the stroke, yeah, maybe around 3/4 of pre-stroke ability, then you can now say we can give it 4, right? A little bit more than that, you can give it 4.5. If the patient actually used the weaker arm as much as he used it to before the stroke, you can give that 5. So that's for that. And you can also read the what they call it, the quality as well, the quality of the use. You can also, yeah, this we rated actually the frequency, the quantity. You can also as well use that to some extent use that to rate. So my take is that about assessment of patients upper limb post stroke is that we tend to be busy clinicians actually, particularly in our own health system. We have so many patients. Assuming you have so many patients and you have to use all these outcome measures, motor activity log, wall motor function test, upper limb self-efficacy test, Jefferson hand function test, 9-hole peg test, and all that. Many of them, even those stroke impact scale, upper limb Fugelmeyer, all of them, right? So let's say you have to use them to know that getting better, right? So if assuming I'm a busy clinician, I think that's actually not going to be actually possible for me. I think we can also devise a means. Yeah, we can sit down in a clinic and look at those activities, those performances, those task performances that I think they are very relevant to environment, and agree upon them. Okay, when our patient comes, these are the things we will definitely assess. Yeah, I think I can give a clue. Taking hand to the mouth, I think you can assess that as function, because we take our hands to our mouths many times in a day to eat or to drink water, right? Maybe washing our faces, or maybe picking your phone, carrying it from one place to another. We use our phone frequently now. We answer calls, we make calls, and all that, isn't it? You can also, okay, writing. The patient can be able to write, and you can read those skills. Yeah, you can use these rating procedures by Stephen Wolf and Stephen Wolf. Yeah, I think for the Wolf and both for Mal and I think by Stephen Wolf and his colleagues. So you can use that one actually to rate. So what an outcome assessment means is what? Is to have something that you can rely upon that can help you to know that your patient actually is at this particular state at the moment. And after some time, you also do that again and see, okay, maybe a patient has passed the previous state and he has now improved. So that's the way you can. I can remember in 2005, one of my patients, one of my neighbors, had a stroke. At the time I was about to graduate, I think maybe around 3 weeks or so before I graduated from Bayero University Kano. This patient came down with stroke. Unfortunately, this man sadly died about 10 days ago. I think that's what actually made me also remember. I went to manage this patient, and I was just like, okay, I need to just do a lot to see that this patient got much, much better, work like me, and do everything like me. But after some time, this patient said, okay, hi, he thanks God, and he also thanks me. Partly because, majorly because, before I started, he wasn't able even to sit up from his bed, even to sit and stand. But now he can even stand. Even the only thing he could do when I started was just moving his head. But now he can stand. He can perform Muslim prayer, yeah, standing and prostrate and do whatever it takes, right? So now he has, yeah. So if this person has not told me, all I thought that I didn't do anything. Yeah, so we have to really look at our environment. What are the things our patients actually do, and how do we use those things to assess their progress, right? So you also ask the patient themselves also, do you think, have you seen any progress? Yeah, he tells you, okay, I couldn't do this before, but I cannot do this. So these are the things that you can also use. So for the intervention of upper limb, like I said, I'll concentrate on motor functions. There are so many things that can be done. You can use neuromuscular interventions. The use of the PNF, NDT. I think this one is from Pollock et al. In 2024. They look at the evidence actually. So use of assisted devices, what is called the robotic rehabilitation, assistive modalities such as transcranial magnetic stimulations, transcranial direct current stimulations, a lot of intervention that can actually be used. But I'll concentrate on exercise-based interventions, and in particular, I'll talk about their evidence from the literature. So that's what I'll talk about. So I have my own algorithm actually that I actually use for management of upper limb. So I consider those that have severe impairment, and by severe impairment are those that can't. Maybe those that have is score of 0 or 1 on motor activity log, and those that have what they have a very low score when you take the median, the mean scores on well motor function test. Of course, I can also explain severity in terms of if I ask my patient cannot do anything, yeah, cannot do anything, or they cannot perform any functional movement, I can call that actually a severe. Maybe they can just move the hand a little, but they cannot perform any functional movement. I can call that a severe impairment. So when we have patients that cannot do that, have severe impairment in motor functions, what I actually recommend, and what literature actually recommend as well, is the use of the mental practice and motor imagery. Mental practice and motor imagery. Motor imagery means usually task observation, action observation, and mental practice. Then the use of neurotherapy and the use of robotic rehabilitation, and also the use of passive movement as well. Yeah, so the use of passive movement as well. Yeah, so I didn't see any recommendation for that in the literature. The use of passive movements, but from the literature, actually, there's even recently this year, I think about a couple of months, we published a systematic review on the use of passive movement for upper limb rehabilitations, and we found it actually improved. Though the evidence actually is actually low, it improved motor functions and disability. So you can also use other adjunctive therapies like the TDCS, the TMS, transcranial magnetic stimulations. I won't talk about that today. Vagus nerve stimulation as well. So for those with mild to moderate impairment, yeah, those that have what an appreciable motor ability that they can perform tasks themselves. You can use what task-specific training. You can use CIMT. You can also use the what hybrid therapy. By hybrid therapy, I mean combination of more than one intervention. I think this is what I actually recommend. When we come to the recommendation aspect, I will talk about that. So I don't know. So please, my time is I still have time.
Yes, you still have time. We have 2 hours, sir. 2 hours.
Oh, that's wonderful. That's wonderful. So I will talk about first of all interventions that have to do with what in cases that are what the motor functions is severely affected. What I call the maybe passive forms of interventions, if I may call it. So I'll talk about action observation or task observation. So by action task observation, it means the patient sits. Yeah, let's just assume the patient sits in front of a second person, or maybe a screen where you play a video of someone performing task. So what the patient does here is sits and observe that person. The person will observe tasks. What you do now as a therapist, you have the patient and you have another person, or you can serve as another person, you yourself, you sit in front of the patient, then you perform a task. For instance, you raise your hand, or you carry a cup of tea, maybe a cup of water, and take it to the mouth. You ask the patient to observe, right? You ask the patient to observe. You can carry out another task, maybe transferring a phone from one part of the table to another. You ask the patient to observe. Yeah, so in the literature, the way this is actually performed is actually variable. In some of the literature, this is actually performed for 15 to 30 minutes or for 5 days and up to 4 to 8 weeks is actually performed. You can also use number of repetitions. In some of our studies, what we did were number of repetitions. So what we did was we just asked the patients to repeat this task about 200 times per session, 5 times in the week, and for even up to 8 weeks, 6 to 8 weeks. I think that's what we did. There's one we did for 4 weeks. Yeah. So what you do now, you can have so many tasks. I will show the tasks example of tasks that you can give. You can just agree with the patient the type of task you want to do. Particularly, the patient is very familiar with them. I think are much easier for the patients, right, to observe, and actually better for him to observe, because those are the ones that the one he's actually familiar with. You can use yourself. You can use a second person, a relative, a spouse. You can also use what? You can also use what they call it. You can also use a video, a screen to show someone doing the task, and the patient will see. And yeah, I think I will prefer that the patient maybe use the video at home. You can have a video at home the patient can use, and so that practice at home. While it comes to the clinic, you can do that, and the patient observe what you do. So the rationale, neurophysiological rationale for that is that inside our brains there are some neurons that are called the mirror neurons. It's just like when you put a mirror in front of you, you will see yourself, right? So the same thing now, if I observe someone performing a task, those areas of his brain that are activated when he's performing those tasks will also be mirrored, will also be activated in my what? In my brain. That's the theoretical assumptions of the task observation. Yeah, so you do it as much as possible. It's also called the mirror neurons, or they are called the social brain. And this relates to why, if we are together in the company of so many people and someone yawn, there's likelihood all of us or one of us will also yawn as well. Maybe we are in a company of so many people and someone said, okay, I feel like peeing, I feel like urinating. Another person will also feel like urinating. Because of what? Because of what they call contagion. So there are actions actions that we perform actually are contagious. And these contagion neurons in the brain are called the mirror neurons because of them. So this actually, we'll talk about this evidence and the level of evidence of this, and we'll see what actually, yeah. So, but I recommend that this is actually needs to be better carried alongside with what is called the mental practice. And when you do action observation plus mental practice is called what? Motor imagery. I'll talk about mental practice and I'll come back to the motor imagery and talk about that. And also talk about how we did it with one of my students, although the work has not been published, but I think it's actually a very creative work that we did. So mental practice, unfortunately, there is no clear pattern or dosage that is actually being done. It can be done for 30, 45 minutes, up to 60 minutes. And it can be done up to 200 repetitions, 300 repetitions. Yeah, so, and in mental practice, what you do, the patient will imagine carrying out those tasks in his mind. And this one was what? Was borrowed from psychology literature, sports psychology, for psychology. Yeah. So if a sportsman or sportswoman prepare mentally before a tournament or before a competition, they prepare mentally and they see themselves going faster. Let's say they are running, they go faster. They're a footballer, they see themselves dribbling in the dribbling so many plays and scoring and all that. Yeah, that mental preparation actually can help them achieve that goal as they go in the real world into the field. Yeah, so that's actually borrowed from yeah. So what we do in stroke literature is that we ask our patient to imagine carrying out those tasks. For instance, the task I mentioned about, if I do pick a cup from the table and take it to my mouth and ask the patient to laugh. After observing that, then I ask the patient, okay, I want you to observe that. So after you observe that, so I want you to now practice that in your mind. Just practice, okay. You cannot be able to do that with your hand because the impairment is severe. But what I want you to do now is to imagine in your mind that you are carrying your hand, you are picking the cup and taking it to your mouth. Imagine that you're doing that. Okay, you have now lifted it, you have now taken it slowly, you are going, and you have achieved that. This is what I want you to do to that. So you can do that for 30 minutes, for 5 minutes, 1 hour, 200 times, 300 times. We did that in one of the studies, like I mentioned. Yeah. So that's what you do. So while I say this should be combined with a task observation, is actually easier for the patient to do it. If you ask the patient to imagine doing things, it's actually very difficult. But if you do it and the patient first of all do task observation, so after observing the task, I do one task one time, repeat it one time, then the patient observe it, and you now ask him, okay, please mentalize that. Imagine that you are Imagine that you are doing the task in your mind. So after you finish, then I will not go for the second repeat. I will not repeat the task again. Then I drop my hand again and ask the patient to observe. Ask the patient to observe. Then I drop my hand and ask the patient, okay, imagine that in your mind until he achieves what? Until he achieves that number of repetition, or until he takes that amount of time needed to carry out the task per day. So that's what is called the motor imagery. Yeah. So we'll look at the evidence, and I think this is something that I hardly see people do. The only place it's only one place in my life I see people doing mental practice. One place that I went and I saw that only. So it's not that people are not doing. There are so many things about that in the literature, many systematic reviews as well. So so the issue is the rationale for that is also because in the brain there is also what's called the mentalizing system in the brain also, which actually gives opportunity for this task to actually be to help in exciting the motor cortex. So whatever we do in stroke rehabilitation, for the upper limb in particular here, for movement rehabilitation after stroke, the main goal is for us to just excite the motor system, just to stimulate, to make it work, just to make it work. That's what we do here. Because whether we do anything or whether we don't do, the changes in the brain will actually occur after injury. Neuroplasticity will begin to take place. So it's just up to us to now guide it on the right path. So rehabilitation actually guide the neuroplasticity. While if you don't do rehabilitation, it uses maladaptive plasticity, like I mentioned in the previous lecture. So these are the tasks, example of the tasks you can give. This is from a previous study, but not even on mental practice. But these are the tasks you can give actually. You can see 8 tasks here. So you can ask the patient to repeat those 8 tasks 20 times in a day, each of them during a session. So 20 times 8 will give you around 160, I think, per session. Then you have another session, second session in later in the day. When you put them together, you have about 180 plus 180. That's around 360 repetitions per day for 5 days for 8 weeks. So you can do that. So what I would advise, if you are doing mental practice and task observation, you do them together. When you practice the second, the patient observes you, you do one. Let's say I take number 1, picking up a cup, and do it. If I do it once, then I ask the patient to observe me, then I ask the patient to do it again. When I'm going for the second time, I do it, the patient do it again, observe it and do it mentally. Then until I do the 20 times, until we do the 20 times, then we now go to another task again. We start from 1, he does his 1, 2, he does his own, 3, he does his own, 4, he does, until now do that, all right? So you are not combining, that's what we call the motor imagery. You are combining what? Even though sometimes they also call the mental practice itself motor imagery. But in essence, motor imagery is mental practice from the plus task observation. So you can do that. And I'll come to talk about this because what matters in stroke rehabilitation is actually the most important key factor. In fact, the key there is what? One of the key factors actually is intensity in the practice. How much we do. It's not actually how much we do. It's actually how much what? It's actually how much we do. Yeah, something. If we want to grow our muscles, how much strength exercise we do will determine how much growth our muscles will actually achieve, right? So I'll go to So this is the level of evidence for the tax observation. So from Tizel et al., which is actually on upper limb, a recommendations chapter on upper limb by Tizel et al. In 2020, what they recommend, they summarize the evidence here on use of action observation on what? On upper limb post-stroke. So what they found out is that the evidence actually, so when you look at the green means that what? There is a clear evidence actually. Yeah, there's clear, strong evidence. Yeah, so the green, anywhere you see green, and anywhere you see yellow, it means there is a mixed result actually. We cannot conclude. Some studies have said it's actually working. Some studies say that it's not working. Then for the red, it means there is no evidence at all. There is no evidence somewhere. Yeah. So for tax observation, the evidence on motor function is actually mixed. Some studies have said that's level 1 evidence, level 1A evidence. So I will interpret the evidence later on, and you see what level 1 and level A, level 1B, level 2 evidence, level 3, 3A, 3B, level 4, level 5 evidence are actually talking about. So here the yellow means what? The yellow means anytime you see yellow, the evidence is not actually conclusive. There are some studies that said there is mixed evidence. Some studies said that what? It actually works. Some studies found a negative result. That's for motor function. But for dexterity, if you look at the here, the evidence is green, 1 here. It means there is what? There is high level evidence here. The evidence is actually that it actually improves what? Dexterity. Then there is what? There is for the ADL, activities of daily living, the evidence is still what? Is 1B, a little bit lower than 1A, but there is evidence, there is actually almost a strong evidence that, okay, there is a mixed result on the evidence. Some studies said it actually works, some studies said it actually doesn't. But for spasticity, actually, it works on spasticity. The evidence is green. But for muscle strength, there is no evidence that it actually works on what? Health with. Then for the mental practice, mental practice actually works on motor function. There is strong evidence that it works on the motor function, but evidence on activities of daily living is actually still mixed. There are some studies that said it actually good for significantly improves ADR, and there are some studies that said no, it doesn't actually find negative results. There are also some studies on muscle strength also. There's an evidence, good evidence that actually but actually level 2 evidence, I will interpret that as we move further. There is also level 2 evidence that, okay, it actually works out, helps with improving muscle strength. So the other one is the mirrotherapy. Mirrotherapy is actually carried out usually in the literature between 30 to 60 minutes per day, 5 days a week, and up to even 6 weeks. It can be done for 2 weeks, 4 weeks, usually 4 weeks and 4 weeks to 2 weeks. But maximally, it's actually done for 6 weeks. And how do you do that? What you do that is that you just sit your patient by a table, and you place in the mid-sagittal plane, in the midline of the patient, you place what? You place a mirror. But in most cases, the best way to do it is to slant the mirror a little bit towards what? Towards the unaffected side, a little bit slanted towards the unaffected side, so that you can be able to observe to see the reflection of what? Reflection of the unaffected limb, as though it's actually the affected limb. So if you now sit, let's say in this picture, you can see the patient is sitting, and in the in his midline, there is a mirror placed, so you can see affected limb is actually the right limb, but it's been made to what? To perform task with what? Unaffected limb, which is the left limb. So what this does is that as he looks through the mirror, he will see the reflection of what? Of the left limb, as though it is actually what? It's actually the right one. Because what we call in physics the principle of lateral inversion, right? So our image is actually laterally inverted when we look through it in the mirror, isn't it? So now, if you look at it in the mirror now, it looks as if what? It's just showing what? It's just showing. It's just exercising what? Exercising the right hand, which is the affected one. So what happens is that what does happen? It just actually gives a visual illusion of the movement of the field, as though it's that of the what? The affected, what's called the principle of lateral inversion. In this, the visual feedback from the mirror is received by the premotor cortex, a key actor in the control of movement. So now, that visual feedback that he receives from the mirror, that he sees the left hand as though it's the right hand, will now be received by the premotor cortex. And the premotor cortex is what? Is actually a key word, a key principal actor, or a principal actor in the control of human movement. And that will help a regulating what? A regulating function of the what? Of the affected hemisphere. And that might induce changes in the brain that can cause what? That can cause improvement in functions, right? So we look at the evidence in the literature. What's actually the evidence? What outcomes this intervention has been able to improve? So neurotherapy level evidence from Teasel et al. I got this from Teasel et al. So there is actually level 1A evidence. If you look at this one is green. Like I said, there is evidence actually. Evidence, it shows that there is evidence that there is even the evidence, even level 1 evidence, it significantly improves what? Motor function, according to result of about 50 randomized control trials. 50 randomized control trials. Then it's also improved dexterity, but the level of evidence is about 1B, 2 randomized control trials from the result of 2 randomized control trials. But for spasticity, the result is actually mixed. Some studies actually found out that it actually improves activity of daily living and spasticity, but some studies actually found negative results, so we cannot actually conclude. And the evidence on this is actually level 1 evidence, so we cannot conclude that it actually does that. Then it also improves proprioception and stroke severity, as measured using the National Institute of Health Stroke Scale or modified ranking scale. Okay, probably they use the National Institute of Health Stroke Scale. So the proprioception stroke severity actually also, there's actually high level evidence, 1A or 1B, based on results from 1B for the process in 1 randomized control trial, and for the stroke severity, a result of 5 randomized control trial. That actually is unequivocal. Actually, it actually significantly improves both proprioception and stroke severity. Then for the muscle strength, there is actually a mixed result. There are 2 studies actually. One said it improves and it doesn't actually significantly compared to probably other interventions. Yeah, other interventions. That's for what? For neurotherapy, right? Then coming to this one, the constant induced movement therapy. And so those ones that we talked about earlier, the neurotherapy, the motor imagery, the mental practice, the task observation are usually done what? You can also do them with moderate to mild impairment. You can do that because what is now being advocated is the use of what? The use of hybrid therapy, where you combine more than one interventions just to maximize the benefits for the patient. So they can also use for what? They can equally also be used for what? Be used for what? For cases that are mild or moderate, and of course, also there are also methods that are used for what is called the priming the motor cortex. Priming the motor cortex means that preparing the motor cortex for action. So what happens with after stroke is that the unaffected hemisphere tends to dominate. The affected one. Just the same way that countries that have stronger military strength, they tend to dominate others. Recently, Nigeria thwarted coup in Benin Republic because Nigeria has stronger military strength than Benin Republic, right? Right. So Nigeria can dominate those countries because they are weaker countries, isn't it? So in order to normalize the dominance of the unaffected hemisphere over the affected one, we can use what is called the priming intervention, priming system strategies, One of them you can use motor imagery, you can use mirror therapy, you can also use, before you do the active ones, right? So you just start with them, just to prepare the motor cortex for action, just to normalize them. Yeah, and so you can also use what is called bilateral arm training, use of the two hands to perform tasks and all that. You can also use TDCS, neuromodulation, TDS, TMS, and all that to stimulate the motor cortex. So you can do that. So for the mild to moderate impairment in motor function, we can use what you call constant inducement therapy. And we look at the evidence, we look at by the recommendation when we are done, and we see which ones we can be able to use our patients. And we see also which ones we can combine together to maximize our patients' benefits, right? So this constant movement therapy has so many components, but there are three basic components that it actually uses. What it does is that it uses what is called the mitt or the sling, a constraint. What it means is that, yeah, it was derived from the concept of the learned use phenomenon that we talked about earlier, that people learn behaviorally not to use the affected limb, right? So in order to force them to use the affected limb, you just constrain, you just use something and tie, and prevent the unaffected limb from being used. So if you do that, definitely the patient may actually be forced to use the affected limb. That's how it actually started. And initially it was called forced to use. Forced as in forced, right? Forced to use. Initially it was called forced to use. It was later that it's now become constant inducement movement therapy, because other components are also added. The use of mass task practice. Initially you just tie the unaffected limb and just allow the patient. The patient will not be forced to see that, okay, maybe if he wants to drink his water, if you want to do this thing and that, I have to what? I have to definitely try and attempt to use the affected limb. And as such, that may result in what? That may result in its improvement. So in essence, the first use and the mental practice almost look like similar things to some extent, if I might just try to relate them, right? So like I said, the CIMT has three components. One is the constraint. The constraint is that just to tie, just use anything to prevent the use of the unaffected limb, so that it will encourage the use of the affected one to reverse learned non-use phenomenon. So when it started initially, the standard use was to constrain the unaffected limb for about 95% of the waking hours. 95% of the waking hours, 95% of the working hours. I think 90 or 95% of the waking hours, right? So for that, yeah. But there are some other forms that are called modified now, where the time taken to do the constant is actually reduced to 6 hours, 2 hours, to even hours that are used during the practice in the clinic or at home. So then another component is also what? Is also what? The mass practice. Mass practice is also so one of the key principles of constant inducement therapy is what? Is mass practice, is high intensity practice. You do it over and over and over and over and over again until what? Until you stimulate the nervous system, the brain to actually recover, to work properly. So that's what you do. So there are ways you do that. Initially, when it started, the standard by Top and his colleague, Stephen Wolf and his colleagues, Edward Top and other, the pioneer, they use the master's practice for 6 hours. They ask patients to sit in the clinic and do 6 hours, just 2 hours, 6 hours practicing tasks. But what we did, analysis of this practice by I can't remember the name of the scientists who did that, who led that study. They analyzed and saw that, okay, people say that they spend 6 hours doing that task, doing tasks with the upper limb. Did they actually do that? Spend 6 hours? It's a lot of time to spend 6 hours just doing one thing. What do the upper limb? I think it's tiring. It's time consuming for both the patient, their relatives, and even the therapist himself, right? So they now look at it. They now found that it's actually about 3.75 or 3.95 hours that were actually used. All the other part of the 6 hours were wasted on doing other things. But the actual hours were about 3. Yeah. So other people also found that, okay, even 1 hour, within 1 hour, they found that, okay, they determine the number of repetitions that can actually induce in patient with stroke when you use the upper limb. And they found that you use about 300 to 600 repetitions per day. you can induce recovery over 2 weeks, and the patient can actually recover, right? And they now found that another key finding they actually found was that those 300 repetitions can even be achieved within 1 hour. So even though we know that, okay, we can do 300 repetitions and a patient can get better in a matter of 2 weeks, 4 weeks, maybe a little bit beyond, why do we waste our time and patient time practicing practicing tasks for 6 hours while we have so many patients? I can have 10 patients with stroke, 5 of them, 6 of them per day, even more than I have to. There are people that some of them that may require attention more than this patient also. So argument on the use of repetition actually surfaced. So now it's either repetition actually used or 6 hours or hours are actually used. And like I said, for the upper limb, usually 300, 600 repetitions. They're recommended for per day for 2 weeks or more, right? But you can also do transfer package. Transfer package is what? Is transferring the gain, making sure to extend the gain beyond clinical settings. So if the patient go home now, in the clinic they spend hours using the unaffected limb. So what about if they go home? What do they do now to extend that again, to achieve, so that they continue to increase the intensity of the practice? So you can do what is called transfer package, which is a contract that you set between you and the patient. Okay, if you go home, this is what I want to do. Anytime you want to use anything that involves the use of your upper limb, please try as much as possible to use what? To use the affected one. Unless if what? Unless if you can't do that with you can't achieve anything with that. Like for instance, when you're eating at home, even though in our culture we use the right hand, you can and is the right hand that is affected now. So what I want you to use, please, it's circumstance. I want you to use what? To be using hold your spoon and be eating with what? With the left hand, even though it will take you longer time, but that practice will also improve your. So you can do that. You can also do that, and you can use logbook to make sure that the patient does that actually at home, right? But one key important thing I like about constant induced therapy is that it's an intervention that the patient can do there. If you not tell them the tasks, you agree upon the tasks they can do, a task they can do at home on their own. So maybe you can decongest your own clinic. They come for the first day or for the first week, they do in front of you. But for the rest of the remainder of the weeks, they only come once in a week. Maybe you can call them at home to find out, okay, are they doing? You can just create a logbook, and the relatives are also overseeing, supervising that to see that they are doing. We've done that even in research, and the patient actually got better. So, like the same tags that I use for the mental practice, we use for the mental practice. There are some ones your patient can use this tax. So you can just agree on the tax the patient can do. You cannot just start and what and agree with the patient and the relatives and see and assess what tax and tax he thinks they can do, which ones are more convenient for him for the meantime, right? Then you can, yeah. In essence, the main goal is to achieve the number of rotations that are required for recovery every day, or the number of hours that are required for practice, so that we can recover. These are things that you actually focus on. So what's actually the evidence? Well, I'm just concerned the evidence here from Susan et al. Is just about on subacute stroke and chronic phases of stroke. But there are so many studies also. Dromeric et al. Is one of them that also look at the safety and effect of CMT, AMT in the acute phase of stroke, patient within just 4 weeks of stroke, and they actually found good results. We also tried on so many patients in case reports on here, and it actually worked actually. But there's nothing we can do. The evidence is about looking at many other factors, how many studies, right? The quality of the studies and all that. So the evidence is actually much more on chronic patients. Surprisingly, the patient that we think we say that okay, recovery happens maximally during early post-stroke. You can see CIMT works much, cause more improvement. Evidence on CIMT is much on patient with in the chronic phase, in the chronic stage. So when you look at it in the subacute stage, for CIMT, there are two forms of CIMT I talk about, right? I said that there's standard CIMT, the one that is 6 hours, and the one and 90% of the waking hour, 90% of the waking 90% of the waking hours constraint. That's the standard CIMT, right? There is also the MCIT, the modified CIMT, because there was argument that it consumes time. So people now shorten it to those practice for 2 hours, 1 hour. There are even those with some with even 30 minutes, and they will constrain for just during the tax practice. Maybe some with constraint 95%, some with constraint for 6 hours, 2 hours, and so forth. So for the CIMT, standard CIMT for what? For subacute, the evidence, there is no evidence. The evidence showed that actually does not actually significantly improve motor function. What was actually found was that, and they couldn't find anything on the proprioception, but on spasticity actually there is a level 3 evidence, and on the muscle strength also there is level 1B evidence. But for modified CIMT, and because modified CIMT, mark you, it actually reduces the intensity of the practice to actually less than the standard one, maybe for 2 hours, 3 hours, 1 hour. So probably it's a matter of the intensity. When you spend less time doing the task, the intensity you achieve might actually be less. Even though there were studies, randomized control study reviews in the past that showed that there is no difference between much. Even the modified CMT is actually more superior to the standard CMT. But I think this is the hello. This is the most updated.
Yes,
Almost.
sorry, listening.
Yeah. So then for this modified CIMT, for the motor function actually, there is a mixed evidence. There is a mixed finding based on level 1 evidence. Some studies reported that it actually significantly improves motor function, but some actually found an opposite. But for the others, dexterity, ADL, and so forth, and all of them, and motor strength, proprioception, actually evidence is actually clear that it actually, at the moment, we can't see it actually improves dexterity, ADL, spasticity, proprioception, and muscle strength. But for in the chronic state of stroke, surprisingly, CIMT actually, there is level 1 evidence that it actually improves motor function significantly, activity daily function significantly, muscle strength significantly, and modified CIMT as well. It also improves motor function, ADLs, but they couldn't find anything on muscle strength. Then the task-specific training, right? Yeah. Task-specific training is just talking about doing continuous task. I can give an example. Using your hand to water your flower. You have a flower, a field where you have your flowers and you water them. That's somehow a continuous task. Wearing your own shirt. Wearing your own. Putting on your own shoes and all that. These are all some examples of task specific training, right? So and you can do that from the literature for 1 hour, 1 day, 4 days, even of 8 weeks. There are studies that showed more than 1 hour and more than 4 times in a week, 2 weeks for 2 weeks, 4 weeks, and all that. So, but the evidence from TISO here showed that task-specific training actually improves motor function, but the evidence is clear that it didn't find any evidence on its improvement that it significantly improves activity of daily living, but it significantly improves spasticity, range of motion. It also improves level 1B evidence, motor strength, but global stroke severity. Actually, they didn't find any evidence on that. That's actually evidence is clear. It doesn't do that. So another, this is bilateral arm training. By bilateral arm training is that bilateral limb training is the use of the 2 limbs together, doing tasks that involve the use of the 2 limbs. And I think it's one of the reasons why probably in our clinics people do what they call the auto-assisted exercise for the upper limb. They use one limb to just raise their shoulders, their limbs up with unaffected limb, right? They do that. But it's actually a very good practice, because one of the things it does is that it helps in coupling the what? Coupling effect of coupling effect. It couples the two hemispheres. It normalizes what? The motor activity with two hemispheres, which is called priming the motor cortex. It actually does that. So it's one of the ways you can also prime the motor cortex before starting any activity, just to help enhance, excite, the facilitate activity in the affected in the affected hemisphere. So that auto-assisted exercise is actually a very good one, but unfortunately, stroke rehabilitation, like I will talk much later, is about intensity. Actually, the intensity matters a lot. The more you do, I give my students all the time example with memorizing a verse of the Holy Quran, or a chapter of the Holy Quran, or maybe some chapters from the Bible. So if you do that, if you want to do that, if I practice particular verse in the Bible or in the Quran, I practice reciting it 100 times, yeah, with the goal of memorizing that, and someone else does that maybe 10 times. Well, it depends on many factors, but ordinarily, I should be the one to memorize better. So the more you do, the better. For the brain, the more you do, the better, because it's also about motor learning. It's about what memory and learning, right? So bilateral arm movement involves the use of what? The two limbs, tasks that involve the two limbs. Maybe carrying a tray of food from one place to another, transferring it, right? And there are also some machines, some tools that are used for what? For bilateral limb movement. So you can employ the use of those ones. So any activity that you think that will involve the use of the two limbs, and the patient can be able to do so, you can ask the patient to do that. But what matters is actually the intensity, how much you do that. So we'll talk about intensity much later, particularly generally as far as upper limb is actually concerned. So the evidence from TESOL that is actually very clear is a level 1 evidence on the use of the on the effect on motor function. It actually improves motor function, but there are mixed findings on dexterity and activity of daily living. And for muscle strength, also, it's actually clear that actually they didn't find any result that said it actually significantly improves muscle strength. So another one I will talk about is orthotic rehabilitation. Orthotic rehabilitation is use of orthosis, and I'm keen about talking about on this because most often times patients come down with spasticity upper limb, particularly it's noisy from someone's end, please. Can we? So thank you so much. Yeah. So particularly as it relates to the upper limb spasticity, the elbow flexor spasticity of the small joints of the hands and wrist joint. So I think because of that, because the lecture is not actually particularly meant for spasticity, and because it's one of the reasons our patient don't actually do well. So I now said I would talk about this, and interestingly, I came across this orthotic device, this sling. Yeah, so I will talk about the rationale behind the use of orthotic rehabilitation. So this one actually, what it does is actually it allows for what? It's a mechanical device that allows for what? That allows for passive movement. It actually allows for passive movement. So it has two hinges here. One at the forearm here. Sorry. Okay. One at the forearm here, one at the forearm, and one at the just a little bit above the elbow. So they permit what? They help in permitting movement at the wrist joint and also movement at the I think it's actually in trial stage, but I think this is something that we can actually do. It's actually creative. It shows that we can actually improvise splints that can help our patients that can help our patients as far as prevention of elbow spasticity, maybe contracture, wrist spasticity, and contracture are actually concerned. So it's actually a mechanical device that helps in what? That helps with passive movement. I will talk about that passive movement maybe a little bit time permits. So one of the things the orthotic devices do, or splinting, that they allow for mechanical actions. For this one, it's called 3D print action orthosis. 3D action or 3D print action orthosis. It allows for mechanical action. The hand is rich in because one of the reasons. Yeah, another thing is what they help. They help in promoting what is called sensory motor integration. Yeah. Sensory motor integration is what is integrating different sensory sources from tactile sensation, from proprioception, from mechanoreceptors, right? And integrate them and what and transform them into what motor commands. And that's helps in what stimulating the motor cortex. So what this is that because here, if you look at it, it helps in allowing movement, right? Movement in the joints, passive movement, and thus uh, 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 if you move the joint, it actually stimulates what? It actually stimulates proprioceptive sensation, and also the presence of the splint here, of the orthotic device here, because it's touching the skin also. That can serve as a source for tactile stimulation. So this thing can be integrated by the brain and be converted into what? Into motor command. So all we need in stroke rehabilitation in helping our patient to recover is to use any means that we see that it can help excite the motor. Anything that, any signal, any message that we can send to the brain that something is wrong, and we need you to work accordingly, right, in the right way, is what we do. So this can help actually. It can provide what? It can have proprioception. It can also provide tactile stimulation. So if you do give a splint like this one is called a volar splint, right? You can also have a cock-up splint, right? I think this one is the volar splint, right? So whatever it is, this one, its presence at the wrist joint here, the feeling that will occur, and the what the keeping the wrist joint in almost a neutral position can help as well in preventing the development of spasticity. One of the problems that we have with the upper limb. So you can use orthotic devices, and I think during the last lecture, the speaker talked about why he doesn't see people with spasticity of the upper limb if they were managed elsewhere, and he suspected that the reason for that could be the use of the orthotic devices to prevent that. So it's not actually preventing spasticity. Actually, it's also stimulating sensory modalities, proprioceptions, tactile stimulations, and that will be converted to motor inputs, what they call the sensory motor integrations. So you can use that. Please, we can use that. I think it's one of the things we now actually do. Most of our patients have spasticity, and so in Hausa they call this the magani agoren yaro, right? Agoren yaro is like you have what to do and you know what to do it very well, but you don't actually do it. So what's the evidence? So the evidence is actually only it was actually found on range of motion, which is actually good. Of course, one of the problems we actually encounter with a patient with stroke is the reduced range of motion, right? Particularly extension range of motions for the both upper elbow and so. If I actually does that, there's level one evidence that actually does that. So we can try that. Although we come to the recommendation was say something otherwise, but we'll talk about. We'll just have to take it this way. Then there's also strength training. Well, I'm not a fan of strength training in patients with stroke. I believe that what we need is just improvement in motor function, and everything will take care of itself subsequently. But the evidence says that it works. So if the evidence says it works, it's one of the things that we can also institute, strength training of the upper limb. And it can be done for 1 hour per day, 5 times a week for 4 weeks, or depending on what your clinical decision making tells you. So we'll talk about clinical decision making So we'll talk about how we can maneuver around all those stuff. So the evidence says that there is level one evidence on motor function, and of course, we are moving the part of the body. Definitely, it will stimulate the motor cortex, and we may have improvements. But yeah, that's what the evidence says. So we have to check that motor function. Then also improve evidence on range of motion, right? Range of motion. Also level one evidence on range of motion. But there is no evidence on dexterity and spasticity. The evidence says that it doesn't really do that for the time they produce this evidence. Then for activities of daily living and muscle strength itself, that's really surprising. Strength training, but does not do anything on say, okay, it does actually. There is actually mixed results. Some studies have found it does work significantly, but some got otherwise found otherwise. So that's one thing about research. So how do you? Sorry, I've been speaking about level of evidence. I think for people to know, for my colleagues, the postgraduate students in particular, and some of us that practice for long, I think they might understand. They already understood what I said, but just to buttress my points. So when we take level of evidence, that 1A level evidence is just talking about systematic reviews or randomized control trials. So if you look at that, whenever we see level 1 evidence in the evidence we mentioned earlier, usually we see it's 1A evidence, right? And you say many randomized control trials. Sometimes there are even 50 randomized control trials in one particular outcome. Maybe let's say motor function, isn't it? So when we have so many randomized control trials, or we have a systematic review of homogeneous, randomized control trials, we can call that what? We can call that level 1, evidence. Systematic review. Evidence from systematic review, not from randomized control trials. Systematic review of homogeneous. Homogeneous means if I use lay term, I call it that okay, there is no much difference in terms of the outcome they use for the assessment, in terms of the type of intervention they use, the characteristics of the intervention they use, maybe probably in terms of the patients they actually used. Then for level 1B evidence, it means there are individual randomized control trials with narrow confidence interval, right? With narrow confidence interval. So that means that the effect size, the strength or the magnitude of the effect of that from that randomized control trial actually has narrow confidence. Yeah, from the upper and the lower limit, the difference of the distance between them actually is actually not actually wide. So that one by narrow confidence interval. If I say okay, there's an effect size of 0.7, then my lower limit is 0.001 to 0.00, maybe it's 0.8, which means 0.01 to 0.0 is actually a hell long journey, isn't it? So that's now that's when we are what broad or large confidence interval. So that's narrow. The different, So the certainty that we have, the level of the certainties that we have is actually not really too wide. So we may be confident that actually the effect is actually the true effect, isn't it? Then 2A, systematic reviews of homogeneous cohort studies. We know cohort studies, right? Expert and honest source subjects. Level 2B is the individual cohort studies. So I don't think in all our cases we have any other evidence beyond 2A and 2B, right? So by level 2 evidence, it means just systematic review of what? Or individuals studies that are not what? They are not randomized, non-randomized control trials. Cohort studies, low quality randomized control. Yeah, even low quality randomized control trials can also be included in this one. So that's what he's talking about, the level of evidence. So there are so many other things that can be used, and vagus nerve stimulation, TDCS, virtual reality, functional electrical stimulations, TMS. Like I said, I will concentrate on this in this lecture on mainly the exercise-based interventions, because lecture was supposed to be even for 1 hour. So it does, because all those things cannot even be talked about in just 1 hour, and that's why we requested for more than. So maybe when we find time in the future, I think the best way to do this is to take individual interventions, or to have a very long period workshop, and we take different interventions with so many speakers. Everybody takes one important one and talk about it. If we will talk about vagus nerve stimulation, I think it will also really exhaust our energy, and vagus nerve stimulation. This one actually, because the vagus nerve stimulation is actually the longest nerve in the human body, which extends from the brain, from the midbrain, right, down to the anus, right? So because of that, it's a traversion. Because that it traverses through all those many major organs, many parts of the body. We can use it. We can use it as a proxy to stimulate effects in those areas, including the brain. Including the brain also. So it's been used, and it's divided into two: the invasive and non-invasive, right? In physiotherapy, we do invasive. We use invasive. The surgeons use the invasive. So I'm very confident in the future, maybe 50 years from now, after we all have gone, physiotherapists may be able to do non-invasive surgeries for their own procedures. I'm confident that will happen. So other things, virtual reality, TCDS, functional electrostimulation, TMS, and other ones, many other ones. So here we look at what? We look at recommendations from some guidelines. One from National Institute for Healthcare Excellence, NICE, and another one from Intercollegiate ISWP, Intercollegiate Stroke Working Party, and European Stroke Organization. So what do they recommend actually? What do they recommend when we are managing upper limb? So what do you do for the upper limb? One, we have to consider therapeutic intensity. It's actually very important. For NICE guideline, they said that if we are doing upper limb rehabilitation, there's a minimum of 3 hours. A minimum of 3 hours for every intervention that you do. There should be a minimum of 3 hours, and it has to be done at least 5 times in a week, 5 times a day every week. It has to be done at least 5 times. Maybe the 2 days are just meant for the patient to rest at home and do nothing. But we can, if the patient is willing, we can also include the whole week, even the weekends. Let him do something. Right? That's by the word, by NICE guideline. But ISWP, they also recommend that this also similar to NICE guideline. But also, the European Stroke Organization recommend as much therapy as possible. Yeah, that's my take also. I think I also aligned with this suggestion from European Stroke Organization. I think the more the better. Do as much as you can. Forget about the intensity should be high. That's the best line. It should just be high. So do as much as we can. Yeah. But we can take those for NICE and ISWAP should be the minimum, at least the minimum per day. Then strengthening training. For strength, they also recommend that the NICE also consider strength training. I don't consider strength training anyway, but I think the guidelines suffices any individual view. That's my view anyway. You can also offer strength training by ISWP. But surprisingly, ESO even strongly recommends strength training. Then for task-specific training or repetitive task training, NICE also recommend that we offer this. They also recommend, ISWAP also recommend that we offer that. But for ESO also strongly recommend the use of what? Use of this. So it's actually strongly recommended. And for mental practice, NICE did not recommend. They didn't make any recommendation for mental practice. NICE is actually a UK guideline, so I'm not surprised. Like I told you, only one place I saw doing this, so I'm not surprised that it's not actually being used. But from the level of evidence that we have, it actually does work on some of the key variables, key outcomes, upper limb outcomes. Then for ISWP, they recommend that we can offer it, but as an adjunct. Yeah, I also feel that if there is a way we can do that, it actually should be an adjunct. And that's why I even recommended the use of combining it with action observation. But ESO strongly recommend the use of mental practice, but as what? as an adjunct to conventional therapy. I didn't talk about conventional therapy anyway. Maybe I'll talk a bit about that, and I will talk about why I didn't actually talk about that. And that's what we actually do. Recommend conventional therapy. When you say conventional therapy, they're just talking about usual care. And usual care, when you look at the literature, you can't understand what is usual care. In some studies, in some systematic reviews, the usual care they're talking about electrical stimulation, maybe PNF, sometimes even strength training. All those are concerned at time as coming. So it's nothing. It's just actually somehow we'll call it a white elephant. So for constant inducement therapy, NICE said that we should consider that, but we should also consider it for people that have, like, remember I said that we use task-specific training and constant inducement therapy for those with mild to moderate impairment of motor function, right? And there are ways you can know that someone is having. So according to pioneers of CIMT, they feel that 20 degrees of wrist flexion is what is actually what is actually one of the signs of having moderate or mild impairment, right? Yeah, and also 10 degrees of finger extension. But I think I disagree with this significantly. And they also ISWAP also almost same recommendation as NICE, but ISO strongly recommends traditional or modified CIMT, either the standard one or the other. So for me, if we do CIMT, for CIMT, I think if you look at all the interventions we talk about, the major thing about them is the major key factor for recovery is the intensity. So if intensity is actually the key factor, so if our patient can be able to move his hands, maybe able to do one task, maybe just do finger tapping, just tap the finger, yeah, or maybe just move the hand from one side to side. I think that's the task you can do. Like I said in Hausa, we say the sanda hannunka kake jifa. It means you use what you have. What you have is what you use. So you just when you use what you have, then you concentrate on that and do it as much as possible. Before you know it, you will achieve something and you build on that. So what I would recommend, honestly, I think this criteria for 20 degrees and 10 degrees are too harsh criteria. They are really actually too harsh. When you look in the real world, when you assess our patient, you see maybe very few of them we can be able to achieve 20 degrees of wrist extension and even 10 degrees of finger extension. So you can compromise here. Your patient can do something, has ability, you can give him that, right? Then for the splint and orthosis, NICE say that you do not routinely offer hand. They didn't say that you shouldn't do it, but it shouldn't be routinely done. That's what they said. Hand or wrist splints. Consider hand or wrist splints for people at risk of immobility due to weakness or increased tone. So you consider use of orthotic device for people at risk of what? At the risk of having increased tone, maybe developing spasticity, or maybe people do too. Yeah. But I think, like I will talk earlier, clinical decision making is actually beyond one guideline or two guidelines or evidence from the literature. It's also based on what I also see, what is actually practicable to me. So if I see that it works for my patients and I can be able to do that, I can monitor and do IO with all the untoward effects of using splint. I think I'll go ahead and do that. And unfortunately, SO does not even recommend that at all. Yeah, and the same thing, ISWP, they said it should be used. It can be used, but not routinely. Yeah, yeah, and it's also yeah, they are also buttressing my point. It also can be done after individual assessment. So it's actually coming back to or going down to individual clinical decision making ability. So how you are able to make decision based on your patient presentation, based on your own knowledge, but based on what you see day to day, and right, and but based on what is also practicable in your own practice, in your own health system. But you remember this, all these guidelines are based on what? Based on mostly the countries or the regions' healthcare system, right? There are things that might not be applicable to us. There are things that, yeah, we can't get ourselves around those things. So electrical stimulation, I didn't talk about it, but there are also recommendations. ISO strongly recommend that, and both NICE and ISWP say that we can consider them actually. Yeah, I also have that feeling we can consider that actually as an adjunct to other therapies. Yeah, not for anything. We are using it as a source of sensory motor integration, sending the signals we are sending, the sensory stimulation that we are introducing, and the ability of when the muscles contract, they might actually move the motion, put it in a particular range of motion, and that can stimulate the joint structures, enhance proprioception, and those can also be what can be integrated and what we call the sensory motor integrations by the brain and being produced or transformed as motor commands. And that will stimulate the motor system. So I think also we can do that as well. In that, initially I wanted to talk about electrical stimulation, functional electrical stimulation, right? Well, you can use you can use the simulation functionally. Yeah, so I think we have idea about that. Then vagus nerve stimulation also. NICE did not recommend that, but ISSW said that we can consider that. European Stroke Organization ESO has not made any recommendation on the use of vagus nerve stimulation. NICE said we can consider neurotherapy. European Stroke Organization said they have not yet. Yeah, we can just forget about them, but we can consider that as an adjunct to other interventions, isn't it? Particularly in cases where patients have severe impairment, we can consider that. So robotic therapy, I didn't talk about robotic therapy, but I don't actually recommend that, but strongly recommend that, but as also an adjunct. So you can see most of these interventions, technological interventions, robotic stimulation, vagus nerve stimulation, TDCL, virtual reality are usually offered as adjunct to other interventions. Virtual reality is not even recommended by ESO, but they just mention some. But they actually consider. ISW recommend us to consider that, but in a period where we are doing in a situation where we are doing telerehabilitation, doing virtual reality structural rehabilitation, we can consider that. We can also consider in the context of our limb rehabilitation, some VR by. So I didn't talk about this one, so maybe when we have time we'll talk about that. So how do we make clinical decision? Yeah, concerning what we talk about and concerning upper limb rehabilitation. Yeah, clinical decision making is just talking about three things and maybe a bit one of their supporter. We have you're just talking about your clinical expertise, what you do. Client also preferences, research evidence, right? So we look at the evidence now. We mentioned the evidence. So it's up to us now to use the evidence based on what is actually in the evidence. Yeah, and our own clinical expertise as well. Okay, there's evidence on this. There's evidence on virtual reality, but we don't have the gadgets to do that, right? And we don't have the skills to do that. There are those for robotic rehabilitation, but we don't have skills to do that. So why don't you go for those that we have skills on, which have more evidence even done all these technologically advanced gadgets or intervention tools, right? Then the client preference also have, yeah, even though we know that, okay, this is what the evidence says. This is what the evidence says. If a patient said that he doesn't want this, I don't want this. For instance, if I'm to give constant induced movement therapy, and my patient said that he doesn't want the constraint, it's somehow, why will I be carrying something in my hand, tying my hand with something for the rest of the day? I need to go out. People will see and will start looking at it on all that. So your clinical decision making will come to play here. One, you either choose others, maybe task specific training. Or you can say, okay, of course, even the constant inducement therapy, there are people that I think Christina Brogard in Sweden, I think she did compare constant induced movement therapy with the constraint and without the constraint. So you can also as well use the constraint in movement therapy, but without what? Without the constraint, behavioral constraint. Ask the patient, okay, what I want, please. The main essence of this constraint is to prevent you from being using the affected hand in carrying out daily activities or functional activities. Yeah, so if you can maintain yourself and what? And not use the hand, please do that. Behavioral, do that. Just anytime you want, consciously, anytime you want to do something, do it what? Do it with the affected limb. So that's what we also, the environmental context will also come to play, right? In our environment, we see so many patients at a time, and we have little or no clinical decision-making support systems. In other places, they have clinical support systems. They have computers that can, okay, they can just input the patient characteristics and they tell them, okay, this is the best thing we do for the patient, right? And we have other support systems also, maybe therapy assistants, people who I know there is so much politics on this nowadays, on the issue of therapy assistants in the country, so I don't want to delve into that. Yeah, so there are not much environmental, you have to consider the environmental context. And if the patient actually pay for those interventions, and you see one is actually more costly than the other, so benefitly, and the patient is actually of low socioeconomic status, even though it is the best, actually, you can still go for the what? And that what will bring us to what we call the problem solving, right? What is called the clinical reasoning. In the clinical reasoning, it means that if you are making a decision or managing a patient, not only for the upper limb, be it for anything, the thing is, you have to identify. You do the assessment, and you know what's the problem at the moment. What's the problem? What's the problem the patient has? Okay, the patient has a problem on this, on this, on this, on this, on this, and that. Right? So what do I do to solve this problem? Then I can develop alternatives. The patient has impairment in motor function, and this impairment is what? It's moderate. So what do I do? What do I do? I say, okay, for moderate impairments, I can do task-specific training. I can do bilateral arm training. I can do neurotherapy. I can do mental practice. I can do task observation. I can do electrical stimulation. I can do a number of them. So what I will do in terms of this in problem solving, I will organize them based on what I feel is the best, based on my own clinical decision making. My best might not be the best from the evidence per se, anyway. Maybe my best based on the practicalities of my own healthcare system, isn't it? So I just arrange them. Okay, I'll give task-specific training. If it doesn't work, then I will add another thing. If it works, then I will consolidate and say, okay, how do I improve? That means what you now select the best alternative out of those alternatives. You have alternatives. Okay, this is what I have, but let me choose the best. So if you now implement the best, if it works, that's fine and good. Even if it works, you still assess, right? And you also consider the patient pays for money. Maybe he pays for, when you do task-specific training, the patient pays, let's say 1,000. But when you do another intervention, and the patient has gotten better, so maybe you can reduce the dosage, you can reduce the frequency of the treatments, you can ask the patient to be doing it at home, just only show up once in a while, maybe once a week or twice in a week, actually to prevent the patient from spending more and all that. So it actually, yeah. So but if it doesn't actually work, you have to now go back to the drawing board and look at, okay, it didn't work. Out of those alternatives, which one can I now institute? Which one can I introduce? So I'll introduce one, just trial it and see. So that's what, yeah. The only problem we have in our practice most times, when we do one thing, we don't actually check whether it works or not. The patient comes, we just send them to the gym, go and do multi-gym, go and do reciprocal pulling. They go and we don't even know what they are, whether they're getting better or not. Yeah, we just allow them to. We hardly even assess. Maybe assessment comes once in a while or long. So my my final tips are that please, every effort counts in stroke rehabilitation and upper limb rehabilitation. Every effort, even the conventional therapy that we're talking about, the use of the reciprocal pulley, the use of the gym for the strength, they all actually count. Yeah, they actually count. Yeah. The conventional therapy, the use of passive movement. One of our students did a work a couple of years ago where we compared the use of mental practice, motor imagery, combined and with pass movement separately. What we argue that pass movement is actually one of the key interventions that we give in this country. But do we do it actually the right way? Does it actually utilize the intensity that is required? So we now recommended for the use of high intensity. I think we did so many we did for so many joints of the upper limb. We did pass movement for this and with high frequency of repetition. So everything counts, please, whatever you do, but you make sure that you start early, start as early as possible. Yeah, start early, right? When you start early, you catch them young, isn't it? So you start early because, like I said earlier, whether you do your rehabilitation or not, the brain will try to reorganize itself. So if you have, if you train heavily in the night and in the street there are no gutters to carry the water to drain it, what will happen? The whole street will be flooded, right? But if you have a good gutter and it's not packed with debris and all that, it will not flow freely and it will get drained, isn't it? So the same thing, if you do rehabilitation, you are guiding, just like that drainage, you are draining, you are guiding the rehabilitation to the improvement, the recovery, the neuroplasticity to go in the right direction, right? So use as much in high intensity as much as use high intensity as much as possible. Use high intensity, please. Use that, yeah. I saw a paper when I was preparing the last talk I did for the NSP on the pen and central nervous system pen. I came across a paper. The paper has not been published, but it's available online on preprint, and you can cite it. You can talk about it from Institute of Neurology, University College London, UCL. I think what they found out is that in as much as you give high intensity intervention, no matter the chronic stage of how chronic the state of stroke is, there are signs that you can achieve you can achieve improvement. Even the improvement that as we know, yeah, it takes it goes actually slowly when it's actually old. As the older it is, it actually goes slowly. But that new paper, which I think will maybe published sometime next year, is actually pointing to the fact that high intensity practice, high intensity intervention is actually the way to go for helping our patients to recover. So we do that, right? Then you also use hybrid therapy. Hybrid therapy is the combination of one or more interventions. Of course, even the guidelines, they also recommended using others as adjunct therapies or adjunctive therapies. You also use what? You also use clinical reasoning, yeah, problem solving. When you start this, please evaluate it after some time, see whether it works. If it doesn't work, there's no shame in that. Choose another alternative and go for it. Or maybe add another thing, isn't it? Then you also, as important as everything, please assess your outcomes. Assess your outcomes. I gave you an example with one of my patients, one of that I lost just about 10 days ago. One of my neighbors who had stroke about 20 years ago, just shortly before I graduated. That patient, I managed him, and to my naivety as just out of school, let me call myself graduate. I was not even a graduate because I was not given my certificate at that time. I thought that the only way I could help that patient is when the patient returned to normal as I am, as young as I was at that time, as agile as I was at that time. That's what I thought. But the patient proved me otherwise. He told me that, okay, we started this thing when I could only move my head. I could not sit up in my bed, talk less of sitting and standing and transferring. But now I can stand, perform Muslim prayer. A Muslim prayer requires so many activities: standing, bowing, prostrating, standing up again, sitting, a lot of things. But he can do that. He said, okay, that's all he needs. At that time, I think he was around 65 or so. I think he died just maybe around 85 years or so at that time. So assessing our outcomes, I didn't assess outcomes because I didn't assess. I didn't have any outcome to assess. I was just managing, thinking that my outcome will only be when the patient return to work the way I work or return to do things the way I do. So please assess that's the final tip I talk. I think maybe that's the last, and just have some references here, even though I have not included some maybe of the references. I will do that update before I send. So thank you so much, and I hope we and 102 tenths. So thank you so much for your time. It's not easy, I know, to wake up around 7 a.m. and to come for a lecture like this. So maybe it's something that we can discuss in the future too. Thank you so much for listening to my talk this morning. So please,
thank you, Prof. I really appreciate you for having time to give us this an elaborate and highly educative lecture. Thank you very much.
Thank you so much. Okay. Is it better that I spoke right? Better, right? I thought it's one small boy. It's okay. It's fine. Okay.
Yeah, thank you, Prof.
Thank you so much, sir.
Is there room for questions?
I think questions and contributions in particular, right?
Thank you, Prof. let me comment.
Thank you so much indeed. You want to add something? You can add something, right?
Yes, I just want you to highlight to us whether all the evidence applied to what's the link with the cases in pediatric cases compared to adults. Any link or any more light regarding this?
Actually, I didn't look at that. But I know, like, for instance, for constant in this moment therapy, I know it's actually been done for people with children with cerebral palsy, for instance.
Hello.
Yeah, I think I didn't look at that actually, but I know for in particular constant in this moment therapy is actually being used for there are a lot of studies, a lot of systematic reviews even on that for children with cerebral palsy. But I did look at the evidence, and I concentrated on only adult stroke actually. That's my. But I think we have a specialist on in the area of pediatric rehabilitation here. I think maybe he can add some things. I think Dr. If everybody is here, I think he should talk about a little bit on the BOBAT, if it's possible, and the PNF. I think he has some work, so many things. He has done so many even certificates on that. Yeah, I didn't actually include that because I didn't see from the evidence based, especially the one I used by the Teasel et al. I didn't see any recommendation on the use of conventional therapy. Though I came across a systematic review that talk about its effect on motor functions and disability and I think other outcomes. Yeah, but one thing that makes me actually avoid the use of conventional therapy is actually its broad nature. In one study, they will say they mean when they talk about conventional therapy, they're talking about electrical stimulation. They're talking about use of neurodevelopmental therapy. Another one will say this. Another one you see they are even including mental practice. They are including a lot of. So what I understand what they mean by conventional therapy usually is what we actually do, what we actually do. So and if you go to our clinics, what we do therapeutic positioning. We ask our patient to rest on their limbs. We do passive movements. We do reciprocal pulley, all those stuff. So I think maybe those ones are the things people mean by conventional therapy. But I think probably, the theoretical framework and even the neurophysiological basis of the movement-based therapy is actually something really remarkable. So maybe we can adopt those things.
Yes. I think yes, we have a recently accepted review.
Okay, that's fine. Okay.
The stories were not many. Modified CIMT normal studies of action observation. There are some evidence, and then meet it.
Is it tax observation?
Action observation.
Okay, for children, right?
Yes, for children.
Okay. Action observation. Okay. But there is no for mental practice, right?
Yes. No.
Okay, that's good. That's a good one.
The action observation and then meet it therapy and then modified CIMT.
Okay, that's good. Okay, that's good. Okay, that's good. And so any other thing? I think is okay. We still have 14 minutes, so we can.
Thank you so much, Professor, for the wonderful presentation. It was indeed marvelous. So, how can we have the slides, please?
Okay, I will share. There are two references I will add. So I will add them and send them to the what do they call it, to the host. I think I will send an email, and email will share to all of us, inshallah.
Okay, sir. We look forward to receiving them. Thank you once again.
Thank you so much. Thank you, Mazu, for. You are still in Italy, right?
No, sir. I back into Nigeria June
you are back?
this
Okay,
year.
okay, that's good.
Yes, sir.
I thought you continue with your PhD there, so you didn't continue with PhD.
Yeah.
Okay. So,
yes, sir. I'll be even coming to pay you a physical visit in the department, and I look forward to.
That would be great. Thank you so much. Thank you. So maybe
thank you so much.
You are welcome. Thank you.
Sir.
Yeah, hello, Prof.
Okay, thank you. Hello, sir.
Yeah, thank you once again for that.
Thank you so much.
Presentation. I mean, we learned that, and this is what we actually need, improving our skills as physiotherapists.
Please, it's not clear. We're not getting you well. Please, can you?
Okay, can you?
Yeah. Okay.
Is it better now?
Do you have anything on? Maybe radio on? You can put it off. Maybe.
Yeah. Is it better now?
Yeah, it's better now. Thank you. Yeah, you can hear clearly.
Yeah, thank you for the presentation once again.
Okay.
So I said that we actually need all this constantly, so keep improving and sharpening our skills as physiotherapists.
Thank you so much.
Yeah. I want to ask, is there? Yes, having said all these, which are all wonderful. Yeah. Yeah, I know that neuropathic pain is one of the things that we see in stroke patients, especially concern, regarding the upper limb. Is there any other suggestion, as regards that, pertaining to the management?
Yeah, I think I spoke about this about a month ago with the NSP presentation. I presented on that. Yeah, and coincidentally, some of the interventions that we talk about here are also some of them that are used for to modulate pain in people with neuropathic pain, especially the central post-stroke pain. I talk basically on central post-stroke pain. So we can use CIMT to modulate neuropathic pain. We can use task-specific training. We can also use mental practice. We mentioned that. We can also use neurotherapy as well. We did that during the talk about that during last lecture. So, but basically, what thing I want you to understand is that in people with stroke, the main goal we want to achieve in people with stroke is to induce the brain to recover and take over its lost functions, either by areas that are injured and they become weak, or either by those through functional plasticity, structural plasticity. Yeah, so this is what we actually want to achieve. So, instituting these interventions modulate the brain, and in modulating the brain, it can also modulate all loss, function that are actually lost, be it cognitive, function impairment, sensory impairment, or motor impairment. So when you look at some of the interventions, even though those ones that are targeting only motor function, some of the secondary outcomes that are measured are usually sometimes pain, like the Fugl-Meyer that we use. Fugl-Meyer is a upper limb Fugl-Meyer motor assessment, or Fugl-Meyer upper limb motor assessment. One of these subsections is actually assesses pain. It assesses pain, and we usually use it as a measure of sensory motor impairment in people with stroke when we give neurorehabilitation for motor functions. So, in essence, some of the things we talk about today, including the ones that we didn't talk in detail, electrical stimulations can also be used to manage pain, and we also talk about other cognitive behavioral therapies that can also be used. Acceptance therapies, we talk about them in our last lecture. They can also be used to manage. We also talk about sensory stimulation techniques, the use of different temperatures, the use of tactile stimulations. We all talked about them last time we talked about.
Okay, thank you so much, Prof. Yeah, I think yes, you have answered refreshed my memory. Thank you so much, sir.
You're welcome. Thank you.
Good morning, sir.
Yeah, good morning, Al-Qasim. Okay.
Thank you so much for the wonderful presentation.
Oh, thank you so much.
My own is observation and maybe some recommendation for our junior colleagues.
Okay, thank you.
Can you hear me, sir?
Yes, I can hear you. I can hear you clearly. I can
yes,
hear you very well.
This presentation I meant. Hello, sir.
Yes, I can hear you. I can hear you very well. I can hear you.
This presentation I meant for us to improve our clinical expertise. So I think for us to have the knowledge best utilized, we're supposed to adopt some of the basic ones that we can use in daily clinic, because we have so many patients. At least just adopt one or two of the techniques and outcome measures so that we've been using them frequently. I think it's going to be of help to us, inshallah.
Yeah. Yes,
we are going to consider all. Maybe as we started, we get bored and stop doing it again. Maybe just adopt some simple ones. Continue practicing it. Asking your mentor, I think it would be better for that.
Yeah,
Thank you so much.
I think let me just chip in something on this.
Okay.
What I actually find easy for me to implement these things is when I read something in the literature, when I like a new maybe skill from someone, what I do, I just go to the clinic and identify a patient that needs that particular service. Then I do all the necessary things, the assessments, implement that, and I publish that as a case report. So that actually serves as a springboard for me, to continue doing that. If you look at some of the pieces I did on constraint in this movement therapy, I actually started from writing a review. Then I now implemented that using case report. Then I implemented them using experimental studies. Then just pilot randomized controlled trials, going to a little bit larger randomized controlled trials. Even trying to see, okay, how do I now transfer that? Like the constraint inducement therapy, I've been able to transfer that it is used for what do you call it, central post-stroke pain. I've been able to use it to manage neglect. Same idea I got, so I just do on my patients, and so that's how actually done. And those things will actually encourage you to do more. Yeah, when you see, okay, I've done this, and this is the output. I have a literature that I can hold on to present and to also share with the rest of the world. That will actually, so as we do that, the junior colleagues will actually adopt. I know adopting practice is actually very, very difficult, I know. And particularly when you look at the structure of our health system.
Yes.
So many problems, so many personal problems by ourselves, so many institutional problems, which are actually outweigh even our own personal problems, right? So referral system and all that. So, but I think it's, we can start from somewhere. Just start from the little you can. Yeah, like I said, use what you have, right? Like the house man says, start from what you can. So thank you. I think we are almost there.
Thank you so much, sir.
Good morning, Prof. Good morning, Prof.
Good morning, sir. Good morning, sir.
Well, I want to thank you and really commend you for a very wonderful presentation.
Good morning, sir. Good morning, sir.
I would like to just, ask if along the line during your surgeon, from a basic physiotherapist to the status at the position you are now,
yes, sir.
While managing stroke patients, is there any way by chance that you might have identified 1 or 2, 3 conventional interventions that can be used given the nature of our settings here? All those complex therapeutic modalities that can be used as intervention are really hard to come by. I'm thinking that if we can find 1, 2, 3 maybe conventional therapies or modalities that can be used on stroke patients that can involve summation, integration, and motor recovery. I think maybe if we can be able to come up with something like that we can be using in our clinics, we can be instructing the junior ones to take up. That would be very, very helpful, because the main objective, like I said, most of the conventional therapies are really geared towards summation, integration, and motor, re-education. So if we can be able to come up with maybe this one, because sometimes you go to our clinics, you find out that most of these visual reality equipments, even simple mirror for mirror therapy, you cannot really find in our clinic. So maybe if we can reinforce, maybe one way we can reinforce the conventional therapies, come up with 1 or 2 that can really benefit our patient with regards to what I just said earlier. Maybe it will help us. Thank you, sir.
Thank you very much. I think probably I should not have anything to say because experience has spoken. So I think I shouldn't have anything. But I don't have any reservation against conventional therapy. Like if you look at my last slide on the tips, final tips, I said everything counts. So the only thing I think I have against the use of conventional therapy, I just believe we don't do them as much as we should do. Yeah, the intensity actually is what actually, the intensity. Even the bobats, that the advocate of bobats now, what are they infusing into that particular treatment intervention strategy? They are imputing some elements of task-specific training for them to achieve high intensity of interventions and practice. So I don't have anything against conventional therapy, but whatever we do for a patient, like I say, everything counts. So we should try as much as we see that what we do actually is do it as much as possible, and that's aligned with the recommendations from various sources. I think I started. So the intensity that matters actually, whatever we do. Then for the advanced technology, actually, for me, there are many things that we can do our own, and everything goes down to our self-efficacy, feeling that are we able to do this or not. There are many things here. Even the virtual reality we are talking about, there are ways we can improvise and have our own. We can produce our own. One of my MSc students is keen on doing something on that, virtual reality. She wants to do something on virtual reality. And I'm not discouraging her, and I'm sure she will be able to do that. It's just for her to sit down and say, okay, how is this actually done? What are the principles? So what do we do within our own system, within our own capability? So I think that's the most important thing. There are so many things that actually they are not actually within reach. We can also create our intervention. I normally tell my students, both undergraduate and postgraduate, that it's not only about consumption of knowledge. You should also be able to bring up your own ideas. When you did, okay, this is a particular conventional intervention that you use, how is it actually done? Okay, how do I make this better? How do I modify it to make better? If you look at the CIMT here, there are so many CIMTs. The standard one started, but now there are so many modified CIMTs, a lot of them. And the people that are looking at them, looking at the loopholes, looking at the things that are not working, or things that they think they are cumbersome, or things that they think that are not for the best of the patients, then people modify them. So we can actually do a lot. We can actually, and the clinicians actually should be the ones to lead us in this effort. Yeah, they are the ones that see the patients day in, day out. So they know whatever we churn out from our own part, they should digest it, look at where they think doesn't work. Then they get back to us. Then we look at, okay, they tell us, okay, you came out with this, but it doesn't really do this. And then we modify it, we throw it back to you. And that's the synergy we should form between the clinics and educational institutions. So for me, the clinicians, they should actually be able to lead. And one of the ways, please, whatever you do, there are things that you've done for your patients and they worked. But why those things are not done is because they have not become literature. And they can only become literature when you report them. So please report them. Whatever you do for a patient, report them, please. Report them, write something, just 2 pages, 3 pages, publish it, and people will see. And others will take it up, modify it, and it becomes literature, and it becomes something that we can do, not just in our country, but something that can be adapted globally. Thank you so much, sir.
Thank you very much, and I hope those that are on this platform are listening to your response to my this, and then they take it as a takeaway home, so that when they get back, they start thinking. Because I want to believe there are a lot of conventional therapies, if documented, if really they have been followed studiously, could have been gazetted, and then it could have been of use to most of us in the clinics. But unfortunately, like you earlier on pointed out, we failed to document, we failed to monitor what we are doing. We just come into the clinics, give our intervention, and then let the patient go without proper documentations, without proper follow-up, outcome measures not being used, and so on and so forth. So I hope with this response from you, and with my little contribution, we can be able to get back to our clinics and start doing the right thing, so that we can be able to help our patients and clients more appropriately. Thank you very much, Prof, for a wonderful
thank you, sir, for the insightful comments. Thank you, very insightful comments. Thank you, sir. I think the experience spoke. Right, thank you. So I think we are 33 minutes beyond the allotted time. Right, the host, I think those are okay. The host, okay, I give you as so who is going to sign us off?
Boppa has left also.
Huh?
Boppa has left also.
Okay, so who is going to sign us off? Naima is not here?
Hello, sir. Before we sign off, good morning, sir.
Okay, good morning.
I've been raising my hand. Thank you, sir, for the wonderful presentation. Can you hear me, sir? Am I audible?
Hello, sir?
Yeah, sir, am I audible?
What do you say?
I said, am I audible? Can you hear me?
I can hear you, sir. I can hear you, sir. I can hear you very well.
Yes. Thank you, Prof, for the presentation concerning rehabilitation of the upper limb. I have some questions.
Okay.
Yes. First of all, I want to ask, because since my years of practice, compared to the modern countries, I discovered that we in Nigeria, I don't think we have this what is it called? These management guidelines for upper limb rehabilitation in stroke. So I don't know, with your presentation, I don't know if you come out with anyone, and if possible, we can have one be it hospital-based or generally for all practitioners in Nigeria, because we are all used to our basic way, of management here in Nigeria. Secondly, I want to ask a patient that he or she is being rehabilitated for stroke, and for more than a year, and the affected upper limb, let me say the right, still remain the power of the affected upper limb still remains zero with let me say as for the specific scale of maybe 3 or 2. Can there be any possible recovery? He has passed a year and the function of the affected upper limb is still zero. What is it called? Sensation intact, sensation intact, but the power is still zero. So can there be possible recovery in the future? And what are the interventions that can be done, to help this patient? Thank you, sir.
Yeah. Okay. Thank you so much, Mr. Sani. Thank you so much for the good questions. For the first one, I think for the guideline, it's actually doable. We can do the guideline, and that's why we are here as a group of those in neurorehabilitation, right? So all of us can put our heads together and come up with something, and we can have representatives that will go around the country to present in different states, maybe the major clinics, and we can encourage people to adopt that. Actually, you can do that, and we can, because I believe this is a national association, so we can do that. We can put our heads together. People from the clinic, people in particular, also people from the academia. We can put our heads together, and maybe also with some inputs from some of our patients, we can talk to them, what works well for them, and we can come up with that. But yeah, that is actually doable for every, not only upper limb, for every patient that we actually manage. I've been to places where I see that even within hospitals, even the hospital, they have their guidelines for what they do for their patients. I have an experience where someone was sent to go for a workshop, and she learned the use of mental practice, and she came and taught all the other members and for them to implement, and they wrote a document for the implementation of that practice in their own clinic. And that one of the major, I think, neurorehabilitation hospital that I know in the country I'm talking about. That's on the other side, right? Then for a chronic case, a very long chronic case with use muscle power, I think it's a chronic case, we can use the muscle power, very severe impairment in motor function, and probably a little bit of severe or also somehow moderate spasticity, right? So if you look at the lecture when we talk about in severe cases, we mentioned interventions that can be used, those that cannot be able to use the hands. They don't have any motor ability to use. Yeah. We mentioned things like neurotherapy. We also mentioned things like mental practice. We also mentioned things like task observation. And we said it's actually even better when you combine the use of task observation with action observation. You start with task observation, follow it by mental practice, and you do it until you achieve the number of repetition you need. The most important thing, like I said, is the repetition, right? And and I cited, what literature actually says is that recovery can occur in stroke even during the chronic stage, but we have to know that it's actually gonna come out really slowly, not as when it's actually new during the acute stage actually, because that's when the rapid neuroplastic changes are actually working rapidly and actually maximally. So yeah, but we can still achieve. And I also cited a paper I saw. It's not been published yet. It's been published as a preprint, where patients with chronic stroke over 4 years were able to achieve some level of recovery in the upper limb following the use of high intensity rehabilitation. So the intensity of the rehabilitation is usually, aside from the time since stroke, early time post stroke, the intensity of practice actually is the major or the key factor for recovery in stroke. So what you do for your patients, you do as much as you do for him. You can use all the ones we mentioned. You can use other conventional therapies, the use of therapeutic positioning, right? The use of passive movement. Yeah, use as many interventions as possible that you think can help improve, help the patient improve his function. Number two that you can do splinting. We mentioned the use of splinting to prevent or to improve spasticity, and which we also look from the level of evidence that is actually work for improving ROM. So one of the key things that people don't suffer from after stroke when they develop spasticity is the loss of range of motion in both the what I call the elbow joint and the wrist joint. So you can do splinting to splint the elbow joint, the wrist joint, those two. Especially if you leave them out, if you leave them in the actually neutral position or in a position a little bit with a little bit of extension in the knee and in the elbow and the wrist. So I think I can recommend that actually. So you can do that. You can also use electrical stimulation. I've forgotten. It's another thing you can also achieve. I said the everything counts. Yeah, and the intensity with which you use that action can also, yeah. So if I would manage that patient, when I would do electrical stimulation, I will keep the hands in a splint. Yeah, I would first of all splint the hand, then I do the electrical stimulation. While the hand is in the splint. So that's what I will do. And but unfortunately, use of splint, the literature is actually not very clear on the intensity of use. Okay, for how long we use it, for how long we use it in a day, for how many times in a week, and it's not really very clear. So that comes down to your own clinical decision. You can trial it and see how it works. Then that might actually become a literature if you report that. So I don't know, have I said something meaningful?
Thank you, sir. Thank you, sir. Thank you, sir. I appreciate it, sir. Because why I'm just disturbed about this. I remember when I was still in Nigeria State practicing as the only physiotherapy in General Hospital of Kwanzaa. I was only in the local government, and I discovered that majority of my patients they recover based on their age difference, occupation, and psychosocial support. Because I discovered that some of my patients that have maybe affectation of maybe the right or the left, and their white collar job, depending on their age, they recover slower compared to farmers, that are 60 years and above. Because farmers, they recover faster. That's what I've seen. But the mistake I did then was not putting it as a research because I don't have a lot of resources, still fighting for employment and so on. So those are the challenges. Yes.
That means those that are younger, they recover faster, right?
Yeah, the younger ones that are white collar jobs, they are doing white collar jobs. They recover slower compared to farmers that are 50 years and above. That's what I discovered.
Okay, yeah.
If a farmer, yes.
For me, I can speculate an explanation for that.
All right.
It's actually activity dependent. Those guys are farmers and they use their hands for farming and all that.
Yes, activity dependent. Yes.
Yeah, so it's activity dependent. So that maybe the activity they do is much higher than those ones in terms of because they are farmers. Probably they find ways they compromise to do some level of work in the farm with the hand. That might be one of the reasons. So those ones are observational studies, so we cannot actually say this is what happened. But I think one of the things we can speculate, right? Yeah. So I think one advice I will give our clinicians is actually for them to be documenting what they do. Yeah. Our clinicians do very wonderful jobs. Day in, day out, they do things that help patients recover. But unfortunately, they don't document these things. And if you don't document anything, you document and produce it, and for the rest of the world and rest of the people in the country to see. Honestly, it's like we are wasting our own practice. Yeah, because you are supposed to be the leaders, right? You lead, You did something and it works. You tell us, okay, this what works, what worked, and what works. Then we look at it. Okay, what are the factors that make that those things actually work? Then we now go into research and find out, and we bring back those things to you to also trial, and you now find things better. So that's the synergy that should happen between the clinicians and the academia and the people in the academia. So, but unfortunately, our clinicians don't really. I'm sorry to say this. Yeah, I know there was one man who worked in the clinic many years back. May his soul rest in peace. Dr. Lamina. That man did really well in documenting what he did in his practice. He did a lot of work. He documented a lot of case reports, a lot of things he tried in the clinic to see whether they work or not. So please, if you can imbibe that culture, I assure you we're going to have. In fact, we make the clinical work really seamless. People that are coming after us, our younger ones, will learn from us. Will learn things even before learning to look at the global literature, and we contribute even to global literature. Don't be surprised. Something that a report that you just write today, after maybe reporting on your patients. Don't be surprised that in the next 2 years to become a global, maybe in the next 5 years to become a global practice. Someone has seen it and conducted the research and he found it actually works. So I think so. Please, maybe it's the culture we should imbibe.
Yes, sir.
Can you hear me? Yes, sir.
I can hear you, sir.
Yeah, I just have some. Yes, I just have some recommendations which I feel it will be helpful to us as neurophysiotherapists.
Okay.
First of all, my first recommendation is this: that despite the challenge in the country, our day-to-day documentation should be consistent. Should always be consistent. One. My second recommendation is this:
So
when
I didn't get the first recommendation, sir. Sorry.
Yeah, I said our day-to-day.
I can hear you, sir. Hello, sir. Oh, our time is off. On. Hello, sir. Okay. I think it's out of. Okay, I don't know. So this man has logged out. Maybe the network locked him out, right? So please, in the absence of anything, this man wants to make a recommendation, but I don't know. Maybe you can make the recommendation on.
Hello.
Okay, we can hear you, sir. The first recommendation?
Yes. Yes, my first one, I said our documentation should be consistent.
Okay,
clinician,
that's true, sir.
Consistent, and there should be a progress. Because in my 13 years of practice, I've maintained that, and I realized when I came back down to the West, I saw that many of our practitioners, they are not helping matters at all. They are not helping matters. And secondly, I want to recommend that as clinicians, I think we should maintain our specialty as we should continue practicing. And if some of us that some of our old senior colleagues that feel they are old in the profession and they don't feel like practicing again, there should be a way of bringing out their mentorship skills in driving physiotherapy practice in Nigeria. Because why I said this was when I came back to the West, I got a job with one federal medical center in Ondo State, and I was shocked. I was shocked that the old physiotherapists, they don't do anything. All they do is to sit in their office from 8 to 4 p.m. And when intern comes, they will just tell them, "Oh, yeah, go and see patients," even coppers like that. So when some of us were like 8 of us that were employed, including me, I was the oldest among them. I started this move that as long as you're a physiotherapist, the people I'm talking about, they are the level of assistant deputy director, deputy director. In fact, all of them now, they are deputy director, and all they do is to sit in the office. In fact, it became an issue that we had serious issue. I have to fight them. In fact, we fought that we went physical. I was letting them know that promotion of our practice, promotion of our profession is very, very important. All they do is to sit down. In fact, it was when we came, me personally, I started fighting. In fact, I fought to the office of the CMD for pushing for some demand for our practice. So we discovered that major physiotherapy departments in some facility, be it government or private, why they are lacking some of these skills and material is because the older physiotherapists, all they do is to sit down. They believe they've gotten to the peak of their career and collecting salary. They don't care. In fact, in my facility here, I had issue with the HOD because he was part of it, and I really fought him. In fact, now I'm even planning to leave the facility to other facilities. But I told them, I said my legacy would speak. Because since we came, I've never had rest. Interns are coming, students are coming for SciWest. We keep training, I keep training, I keep doing, my presentation, training them. And I also initiated some of my colleagues that we are employed together, because some of them have 2-3 experience and 3 years experience, and they are always like, they are scared that they don't work with. I say, no, it's high time we start promoting physiotherapy, because if we can't do it, nobody will do it for us. Nobody will do it for us. So let's fight the fight now. No matter how it is, we will settle later. But my own is, let's achieve a goal of voice. Let physiotherapy, be a practice that is reckoned, that is, being known as a first-class practice, as a first-class profession. But for some of in fact, I came up with modules for intern training, because the HOD came out boldly to tell us, even telling the intern that there is no module for intern training. I was mad with him. I say, even though there is not, you are over 30 or 20 years in this practice. Can't you develop one? Can't you design one? I went all out. I went contacting people, and I designed one, and I told them I'm not giving it, but I'm using it for our interns. I'm using it for our students. So physiotherapy practice, I pray that our profession, see the light of the day. Our older colleagues are killing this profession. They are the ones killing this profession, and it's so bad. In fact, we are still fighting, even as we are on strike now. We are still fighting, and I told them, I'm still bringing more legacy. I'm still bringing out the basic things we know that we've neglected. All of you, including the old, in fact, the old staff, the old physiotherapists, imagine sitting in the office. They don't even go to the ward. I drag them to the ward myself. I dragged them to the ward myself. That what is it? In fact, we got to the ward one day.
So I think
and advocate for our older physiotherapists. If they feel working in the clinic is too hard for them, if we want to move to the academic, what's it called, department, is cool, but they should continue. We should continue to promote. And for those who are still practicing, getting to the level of director, deputy, they should please continue carrying intern and new physiotherapists along by showing them, teaching them skills, old and new. There is no knowledge that is, wasted. Thank you, sir.
Okay, thank you so much, sir. Thank you so much. That's a very good advice. They are actually very, very good advice, and I think we need to imbibe this culture of doing our work really well, not only for the patient, so even for our own selves, because we are being paid, right? So I think it's part of things. Yeah, it's part of things that we can actually change, and change always begins with us. Now that we are changing, I'm very, very sure with time others will follow suit. Yeah, because those ones are aging, even if they refuse to change, they are aging, and they will phase out. Yeah, no matter what, whether they do it the right way or not, they will phase out, right? So when they are phased out, others that you are training now will imbibe the culture, and everything will be good for the profession. So thank you so much, sir, and thank you to everyone for joining. I don't know who is going to sign us out.
Sir, I'm the one. I think I was made the host.
Now?
Thank you very much for the presentation. Out, right? I think I was made... Yes, sir. Yes, sir. Yes,
the one that was signed out?
Oh, yes, okay, I was made the host. I didn't even realize it.
Oh, okay. No problem.
Thank you very much, sir. Until next time.
Thank you all for joining. I know it's really early in the morning. Maybe, I don't know, do you guys intend to change it to another time sometime? Because this early morning is not really easy.
It's not easy. We'll see about it. We'll talk to the participants and see, maybe take a vote and see which is better.
Yeah, for the participant it might be easy, but I think for the presenters also.
Okay,
but anyway,
okay.
It's okay if we insist on continuing on that. I think it's okay. There's no problem.
Okay, but that we made it an option for the presenter to give us either morning or the night. So anyone presenting can choose what time he. Yes.
Okay. I think that's okay. That's okay.
Yes, sir.
So thank you to everyone, and have a nice weekend, and also Happy New Year in advance. Thank you.
Thank you. Okay, thank you so much.
Bye-bye, sir.
Bye-bye,
sir. Okay.